Joy to welcome you all today for today's CME, Postgraduate Surgical Training, The Way Forward. Surgical training is a journey from curiosity to confidence, from fear to finesse. Today's CME is designed to help the young surgeons walk that path with guidance, structure, and inspiration. To begin the proceedings, I would like to invite our respected organizing chairperson and the head of the department, Dr. RAJANI Kadri ma'am, to give the welcome address.
Good morning and a warm welcome to all our esteemed faculty members, distinguished guests, colleagues, and dear postgraduates. On behalf of the Department of Ophthalmology, AJAY Institute of Medical Sciences, it gives me immense pleasure to warmly welcome you to today's CME on postgraduate surgical training. Postgraduate surgical training forms the backbone of shaping confident and competent surgeons. This CME has been thoughtfully planned with the objective of guiding young ophthalmologists in their journey from learning to mastering surgical skills. With rapidly evolving techniques in cataract surgery and beyond, the importance of structural training, positive learning attitudes, and the adoption of new technologies cannot be overstated. We are privileged to have eminent speakers, experienced surgeons with us today. They will be sharing their insights on effective training strategies, the role of wet labs, and modern method of skill acquisition. A special highlight of this program will be the simulation-based hands-on training with the Fidelis system from Alcon. This provides a unique opportunity for our postgraduates to practice and strengthen their surgical skills in a safe and controlled environment. I invite all participants to engage wholeheartedly, share insights, and collaborate to make the most of the opportunities provided throughout this day. I am confident that today's CME will be enriching and memorable experience for each one of you. Once again, I welcome you all for this CME and wish you a productive and inspiring day ahead. Thank you.
Thank you so much, ma'am, for those words and for giving us a meaningful start to today's program. Now, to formally introduce the events ahead, it is my honor to welcome Dr. AJAY KUDVA sir, the organizing secretary, who will share with us the vision and purpose behind this surgical training program and what it hopes to achieve for all of us.
Thank you, Dr. Manya. Good morning, respected faculty members, fellow colleagues, and dear postgraduates. It's truly an honor to stand before you today to speak on the most important and challenging aspects of our medical profession, that is the postgraduate surgical training. The idea for this particular CME, basically when we were planning, normally what we do is we have some of the other clinical topics up and everything. But this time we wanted to do something different, and we eventually ended up thinking about postgraduate surgical training, and especially with our Alcon Fidelis being one of the main important things, because nowadays all postgraduate training is happening on Help Me See platform or the IC platform, and the PGs get a first-hand experience of doing surgery virtually so that they can actually respect the actual normal human tissue when they are operating on the patient. So safety comes first when it comes to all these things. So surgery is not merely about acquiring technical knowledge or learning specific procedures. It's an art, a science, and above all, a lifelong journey of continuous learning, refinement, and dedication. As postgraduate surgical trainees, you are embarking on a transformative path that will not only develop your medical expertise, but also shape your character, discipline, and professional ethics. This period of training is intense, demanding, and at times overwhelming, but it lays the foundation for your future as a competent, responsible, and a compassionate surgeon. The very idea behind this CME was to establish the learning-based system on scientific guidelines that you can practically implement in your surgical training. Every talk today has been thoughtfully curated by our esteemed faculty members whose dedication and experience we deeply respect. Today, I would like to introduce you to the highly practical and holistic approach to becoming a better surgeon, the 10 commandments of surgery as shared by one of my gurus. And let us now explore these commandments one by one and understand their profound significance and surgical training practice. So, keen observation. So, the first and the most important fundamental skill of a good surgeon is keen observation. You must develop the ability to closely observe not only the patient's condition but also the surgical field, detecting subtle signs that can make all the difference in critical decision making during the surgery. Observation sharpens clinical judgment and helps avoid complications. Motor skill development. Now, basically, surgery is more of a skill-based discipline. And beyond theoretical knowledge, a surgeon must cultivate fine motor skills, precise hand-eye coordination, steadiness, and controlled movements. These skills are developed through deliberate practice, repetition, feedback in simulation labs, wet labs, and supervised surgeries. For most ophthalmology PGs, I normally recommend them to strengthen their left hand because as you keep learning surgery, you eventually realize how important the left hand is when it comes to the surgery. So, people start brushing with their left hand, doing their normal day-to-day activity, start writing with the left hand. So there are quite a lot of deliberate things that you can actually start doing to strengthen your skills. Economy of movement and repeatability of steps. So repeatability is very important, and unnecessary movement at every stage inside the eye should be avoided. So each movement should be purposeful, rehearsed, and aimed at reducing fatigue and the operative time while ensuring safety. Mindfulness plays a very important role, and it involves being fully present and aware during the surgical procedure, and which helps in understanding the patient's status and anticipating what might come next. And this helps a lot in reduction of stress as well as maintaining a calm in decision making during the surgery. Visualization of the surgery. Now, this is one of the most important things. What people say is even before you operate on a patient, you should actually operate in your mind. Before you even think about operating on the patient, you need to plan exactly what you are going to do on the table. So that is one of the most valuable lessons that we learn about visualization, and we need to plan the maneuvers in advance, mentally rehearse complex steps, especially in our case, suppose we have zonular instability, keeping a CTR on the standby, or anticipating any of these things. So visualization is very important. Coming to algorithm of the surgery. Now, when I say algorithm, each one of us has a particular step. So when you are doing teamwork, which comes next, algorithm plays a very important role. So for every surgery, we follow a particular pattern or a step, like how a computer program guides the algorithm, are guided by the algorithm. Every surgeon must develop their personal surgical algorithm and a step-by-step systematic approach to every case. This reduces the variability, improves reproducibility, and ensures no critical step is overlooked, regardless of the case complexity. Physical activity, exercise, and rest. These are very important, and they form an essential part of surgical training in maintaining physical fitness and mental well-being. Long hours in the OT demand stamina, strength, and focus. Regular exercise improves endurance and hand steadiness, while proper rest prevents burnout and sustains mental clarity. Teamwork. No surgeon works in isolation. Surgery is inherently a team effort involving nurses, anesthetists, technicians, and fellow surgeons, and effective communication and mutual respect and shared purpose are vital for smooth operation in the operation room dynamics and better patient outcomes. One of the most important things for postgraduates is performance review. So whatever you operate, record. That is what I keep telling students. Record whatever you're doing. So reflection is a powerful tool for growth, and after every surgery, practice reviewing your performance, have discussions, analyze what went well, what went wrong, what could be improved, and how to address errors or challenges. Feedback from mentors, video recordings, and self-assessment sessions help you grow professionally. And last but not the least, keeping yourself updated with the innovation. So whatever new technology comes, we need to make sure that we are constantly updated with the surgical instruments, devices, and the newer technologies that empower you. And never hesitate to learn and integrate the newer techniques and technologies, and never hesitate to learn from anyone. However senior you become, keep your ego aside. If you think that someone else is doing a better job than you, try to learn. Go talk to them, learn the newer steps, and make sure that you are giving something good back to the patient. So in conclusion, postgraduate surgical training is not just about accumulating knowledge or logging cases. It's about evolving into a thoughtful, skilled, and a compassionate surgeon. The 10 commandments of surgery offer a structured roadmap to sharpen your skills, maintain your well-being, and continually expand your capabilities. I encourage each one of you to embrace these principles wholeheartedly, learn from your mentors, practice with discipline, reflect clarity, and never lose your passion for patient care. The journey is challenging, but with the right mindset and approach, it is immensely rewarding. Thank you so much.
Thank you so much, sir, for your thoughts and reminding us what this program truly stands for. We shall now move forward with the first session of the day. When simulation training, give us space to make mistakes, learn, and grow into real surgeries. To light on bridging crucial Kamath to please join us at the dais.
Thank you. At the outset, I'd like to thank the team of this CME. Very powerful CME. I would definitely have wanted even, I agree, there's some problems because not many PGs, but I think the YouTube link is there. I hope that should help. But it's a very pressing demand for the day. It's not, my slides which are coming up will be mainly theoretical. So if the postgraduates have some theory question, you can write it down for that. But otherwise, from my own experience, see, ophthalmic microsurgery, apart from whatever Dr. Ajay just told, is one of the challenges is when you are doing your MBBS, you never are exposed to these sort of skills which you get when you are suddenly exposed as a first year postgraduate to in ophthalmology. Okay, I remember our time when about 20 years back, when there were not, wet labs were there only in the premier institutes, including in our institute, there was only an old microscope to which we used to attach 2 torches and then tie it with the gauze and then practice suturing under it. And there was no structured program. Whereas now if you go to the West, there's a very, very structured program. Unless you have certain number of hours and credits on a simulator or on a wet lab, they certify you, you cannot touch a. Now we are developing now. I was just discussing with madam also. Day by day, early in India, the concept of wet lab was very prominent because you could just join some assistant and hands-on steps immediately. But nowadays, patients are becoming lesser. The patients who want to be operated by postgraduates are becoming lesser. Even CAP patients have become VVVIP. They are more demanding than our special ward patients. So, as we are improving, our nation is improving, standard of living is improving, the cataracts are improving, because improving in the sense, earlier we used to get a lot of mature cataracts. Now we are getting all cataracts in the range of 6-12. So we have to upskill, we have to, there's no room for error. So unfortunately, for that, the training is becoming more and more difficult. And fortunately for us, we have got the wet lab and simulation based training, which will help our postgraduates achieve the skills much, much faster than earlier. So when you go to the aircraft, recently there was an article in the paper that Indigo Airlines, they have blacklisted, so the DGCA has blacklisted so many pilots from Indigo because the simulator setting for landing in Mangalore was not good enough. They were working on a simulator which did not simulate the conditions of tabletop or like Mangalore and similar airports. So therefore there was some problem with the retraining. They had to retrain everybody. So it's very, very essential when you're driving for a pilot to have simulation training. Whereas in our place, in ophthalmic surgery, the eye is okay, one eye, it's nothing like that. It's as important as, flying a flight. Only thing is we are dealing with only one patient, but even then that can affect his livelihood, a lot of other implications. So here what happens is, in the West, there are a lot of studies and there are definitely programs which have a stepwise approach to this training before the patient actually meets the patient. Okay. So the challenge of microsurgery, as I just said, there is low tolerance for error due to a small scale of for the ocular anatomy, and the traditional apprenticeship model has its limitations today. So we need to provide a safe, risk-free environment for trainees, and this can be achieved by mainly two things. One is a wet lab, another is a surgical simulator. So this is what I will be talking about today. So what is a wet lab? I am not going to tell you too many things because it's there. You're going to see it in the afternoon. The whole session is there. I would want you to actually practice it and then see for yourself. But it is something which mimics the real operating room. You can do the surgeries on animal eyes, including goat eyes here. Porcine eyes are much lesser. It's available but difficult to get, but goat eyes are very, very easy. Cadaveric eyes, which are not used for human transplantation, because if they have enucleated the whole specimen and then you can use that. And there are high fidelity artificial eyes which are available for, I think, somewhere around 50 rupees. You get an eye. For certain types of procedures, you can use that. The other things are, you have to get used to the surgical microscope, the hand-eye coordination, the position which you are sitting. All these things have to be held. And then, of course, as sir was saying, your hand movements, your left hand, your right hand, the dominance, how you move your hands under that. And if you're doing phaco, it's hand, eye, foot coordination. So you also have to have your foot moving along the same way. The advantages are, it has a very realistic feel. You can feel the tissue. You can see certain problems. You can try complications. Okay, they say there's something called as buttonholing. So you see when you're doing a tunnel what a buttonhole looks like. You can make some errors. You can see how your hand position is. You can see what actually happens. What happens if you go with your MVR too much into the cornea? What's the Descemet detachment? You can plan all that and you can actually do all that on a goat's eye. There is scope for error so that you don't repeat it on the actual patient. Apart from that, to some extent, if you use cost effectiveness is written here, but to some extent it is cost effective because you can use refurbished equipment. You can use, what we are doing now is whatever we are using, the single use blades which we use for patients, we just sterilize them and put it in the wet lab. So there are a huge amount of blades which are available there, which the PGs are then using for the goat side. Our time it was very difficult to get visco. Now whatever is the remaining visco, we just send it out and then they use it there. So in that way it is more cost effective when we compare it to a simulator. Simulators are really expensive and that is a problem. The problem here, practical limitation, for example, say goat's eye, and I think my postgraduate has made a video which I will be showing here. The practical problem is the goat's eye is not a human eye. So whatever you do and how much more you practice, it's only your hand-eye coordination which you should get, and you should keep in mind that this cannot be exactly replicated in the human eye. Human eye is much more softer than the goat's eye. So there are some limitations, but it definitely helps in getting a hang of it. The other problem here is you cannot have a goat's eye with complication. You can't have there's some things which you can induce, but not everything. You can, inducing a zonular dialysis, inducing a hard cataract or a soft cataract. Hard and soft, to some extent, there are studies which say you can inject different types, different concentrations of formalin and then get that hardness. I have not tried it myself. We do microwave it, but it doesn't work out that well. But some sort of complications you cannot. You have a standard goat's eye. It's only for the initial part which you can help. Mainly it's for your hand-eye coordination. Compared to that, a surgical simulator is much more better. So it's a virtual reality computer-based system. It mimics exactly what you feel, right from the feel to the results which you expect there. You can actually have realistic equipments. You can have an objective assessment. The machine assesses how much more foot pedal you are pressing, how much force you have put in the incision, what would have happened if you go ahead with this, what are the problems in your technique. It flags what are the wrong things which we are doing. So that way you can assess it. From a trainer's perspective, it is very good because you just ask the student to take this module, and in the end of the module, the trainer gets a report card as to this student has got these flaws. Ask him to improve on the hand-eye coordination, ask him to improve on the right hand, ask him to improve on the left hand. All these details will just basically pop up, which we can then individualize and train that particular person. The second thing is you can do hundreds of surgeries or thousands of surgeries. Day and night you can sit. It's like a video game. You just go repeat. You can't get 100 eyes for practicing. How will you dispose them? How will you get them? Mutton shop fellow will not give you that much because he has to sell his mutton. He can, only what is remaining there he will give you. He cannot get goat's eye for the sake of the eye. So it's difficult to procure that. Here it is much easier. The plastic eyes which are model eyes which are there are good, but they are not very good. I'll just show you that in the end. Compared to that, the goat's eye is much better. But here you can repeat it multiple times and there is no problem at all. All you need is internet and you require electricity. And you can get some non-technical skills. Like for example, as you are operating, there are some programs which are there which can suddenly induce a error. Say you are doing and suddenly there is a PC rent. Now what will you do? The person standing on the side will ask, now what are you going to do? So how the person will respond? All these things can be tested out on a simulator. The disadvantage of that, of course, is, I'll forget all the other things, it's the extremely high cost. The cost is somewhere around 4 crores for an ICI simulator, single IC simulator. And we were hoping that some GST rebate will be there. That's also not there. So it's very expensive. In the West, it's a norm, but here it is very expensive as of now. So we'll hope that it becomes, with Fidelis probably they can bring it much better. I do not know. So when you compare it overall, both have their advantages and disadvantages, and we need a combination of both to help it out. So there is a particular way by which you can have a more hybrid approach, where in first phase you start off with the simulator, basic hand-eye coordination, skills, all those things they can try. There are some games in which you have to mark the dots or something like that under that, because first time you take a instrument under the microscope, it's very difficult to adjust to that, so you can use a simulator for that. And subsequently you can use for handling the tissue, the wet lab, and then finally you can have complications and other things which are integrated in the simulator with the basic start on the wet lab. So combination of this approach will help in the in this entire thing to help the student learn cataract or other microsurgery in a better way. Future, they say that by integrating both of the two, we can actually have a augmented reality, mixed reality, and we can integrate it with AI, individual person's problems for the individual case complications can be mimicked, as Dr. Ajay just told that before the surgery you have to run it in your mind. Here you can run it on the screen. So you just run it on the screen, you practice the surgery and you expect what are the problems I might get. Then you approach the patient. So it's for patient safety. Overall, the entire thing hinges on patient safety. So patient's eyes cannot, we try to, of course, complications are an unavoidable part. If you don't have complications, means you are not operated. So you have to have, there will be complications, but at least this will minimize the complications. All right. One more, I think they will be trying it here, where if you are having a good SICS and phaco thing, this is apart from all of this, when you are having a SICS and a phaco thing, a phaco program going together, you can use the SICS nuclei. Usually what happens is we remove the nucleus and we throw it out. Keep the nucleus. Keep it in a bottle or something. It will get dry, that's okay. Just keep it there and use that in the animal eyes later on, and you can practice the phacos in that. So that is somewhat a mix of the best way of wet lab. And simulator, if you have a simulator, there's nothing like it. It's always better. Please, Help Me See and other platforms are there which are giving courses. And soon we will be also starting a course which will be much closer to you. So maybe you can utilize that also. So there's a small video about our wet lab which we use. It's been my course, the video. Now, I'm sorry if the videos are having some problem. I'm not very good at stopping these videos. Yeah. So this is the main setup. So we have a microscope. We have a microscope with a foot pedal that is good for the learning the hand-eye coordination. Phaco machine is there. There's the head. There's a stand for fixing the eyes, goat's eyes. It can also, we have another head which is specifically for phaco. This is the other one. Apart from that, all the instrument trays should be there. There's a microwave which, as I told you, the goat's eyes can be microwaved, not much, it will explode, you have to use it very less. Some other people even give intravitreal. Earlier we used to give intravitreal injection, so practice intravitreal injection first, then do the surgery, but that gives a lot of posterior pressure and you can have a run-out rhexis and all that. So these are all practical steps which some tips I can give you. So you want to know how a rhexis will run off, intumescent cataract when you are practicing, give an intravitreal injection and then try to do the rhexis. Very difficult. Whereas nowadays they are much smarter. They use these microwaves for 4 seconds or 8 seconds, maximum 8. And then with that they are able to do the procedure. Apart from this, there's also simple things like, say the basic things like suture practice, for which there's another microscope there on the edge. And all you can see some IV bottles there on the side. So these are all the pouches which are there are the remaining solutions which we didn't use for the surgery. Once the surgery is over, we use that, and all the remaining things are used for the wet lab. So apart from that, there's television collections, so they can actually record what they are doing. As he was saying, as Dr. Kudva said, you have to actually record every procedure, including your wet lab procedure. To keep a tab on whether our PGs are actually doing the procedure, we expect them to record it and then send us a WhatsApp, so that we know that, okay, they have operated. And so if then they are graded on that. So you can do various steps, including peritomy, and these are the basic tissue handling techniques, including tunneling. I am not a very big fan of this. When I was doing my wet lab, this goat sclera is a bit tougher. It is better to do a clear corneal tunnel in the goat's eye, which gives you a feel of a human eye, because this requires a bit more pressure, but this is how some of my other faculty are training my students. So it's not wrong. You get an idea of the orientation of how deep you have to go, and how you're going to keep your hand. And then other things like the injection of the blue and the side port and all that can be done. And then if you have, I think the next one is the rexis. So all these procedures which are actually done in normal human eye steps, they are repeated, or they are repeatable here. So you can actually do the rexis. All these things have to be recorded also, and you can share it with the consultant for any tips. The goat's eye capsule, if it is not microwaved, feels very much like a pediatric cataract actually. When you're doing a pediatric surgery, it's very elastic. Then apart from this, you also can do phaco. And in the phaco, we can do it in the goat's eye also. But what we have shown you, I just wanted to show you how the artificial eye, which is commercially available, that looks like. So it looks something like this. Only thing is, when you're doing, this is the other head which we have for attaching for phaco, which has a drain, because otherwise the fluid will keep draining out. So the problem with this is the nucleus is, you get a feel of the nucleus. It's a sort of a plastic material, but you can't do all the steps in that. So there are some limitations. This is artificial eye. It's not a goat's eye, artificial eye. Doing the rexis and other things here are a bit more difficult compared to the goat's eye. So for some steps here, we can definitely use phaco. So trenching and other things can be done, including sitting position, how you are seeing, and the foot coordination. These things can be helped done with the phaco. Thank you. I think yes, you can go to the. So we are now the one before this, please. No. Can you just close this, the learner SharePoint? Yeah, can you place my last two slides, please? Yeah. So we are planning or hoping for a center of excellence. That's, I wanted to show this. This is Mr. Karthik there, who will be helping you out now. So we have a tie-up with Alcon, so they were helping our PGs do the wet lab practice regularly. And he's a fantastic teacher. I think he will be helping you out. He's already setting up the wet lab there. And that's the Fidelis, that's not the Fidelis, that's the IC, which we are going to get in Manipal soon. By next month, I think we should be starting the program. At least a certificate course in ophthalmic microsurgical skills will be started by us. So I invite all the medical colleges and all the postgraduates who are interested to apply. And as soon as it's done, we'll be circulating the flyers. So you can come and have a course, even if it is, we want a 2-hour course in the evening from 4 to 6 or something like that, we can tailor make it, so you can come and utilize the services. Thank you.
Thank you so much, sir, for showing us that the wet lab is where shaky hands become steady. May I invite Dr. Devika to kindly present a token of appreciation to Dr. Yogesh. Every postgraduate begins their journey standing quietly in the corner of the operation theatre, simply observing. But observation alone is not enough. The real transformation happens when that observation is converted into active learning. When every step, every gesture, every decision of the surgeon is absorbed and understood. And to enlighten us further on the art of moving from passive watching to active learning, I am delighted to invite Dr. Sarita Gonsalves.
So very good morning to one and all. At the outset, I would like to thank Dr. Rajani, Dr. Ajay and the entire team from AJAY for giving me this opportunity. So the NMC has given us several guidelines as to how we can go about surgical training for postgraduate ophthalmic surgeons. So this talk is primarily directed towards them. So before we go on to all of that, first things first. So having finished your MBBS and then having gone through the rigorous process of NEET training, giving your NEET exams, and finally you've made it here, but then slowly the quiet reality strikes. So your postgraduate course is a 36 months course as per your curriculum, wherein your first 6 months go into initiation, induction, getting to know the department, and your last 6 months you spend as an exam going postgraduate, wherein you're busy preparing for your exams. So effectively you can do the math. You only have about maybe 20 months where you can get your skills right, with all your couple of holidays, some people getting married in between. So all of these things effectively leave you with only a short period of time where you can master your ophthalmic skills. And just like Yogesh sir says, all of us consider this ophthalmic surgical training quite different from general surgical training, if you see. Okay, it's like mastering your piloting skills basically. So it is as fine as that. So as per your MCI postgraduate medical education program, we are supposed to produce competent specialists. So what do we mean by this? At the end of your 3-year course, you're supposed to carry out your OPD as well as your surgical duties professionally and ethically. For this, they have given us some broad guidelines. So medical colleges having postgraduates are supposed to have a standard curriculum. They're supposed to have modern equipment, a conducive learning environment, and of course a peer-reviewed quality assurance programs. But what I feel is that we normally stress on procedures, some which are outdated, like your ECC, maybe a small incision cataract surgery, pterygium, dacrocystectomy, enucleation, evisceration. These are the procedures that we generally concentrate upon. The procedures generally neglected are phaco. Now, of course, we are giving a lot of importance to postgraduate training in phacoemulsification, squints, trabeculectomies, dacrocystorhinostomies, and retina surgeries. So these are the surgeries that we do not normally give importance during our postgraduate course. So dilution of these surgical exposures and experiences are becoming more and more challenging. So what the postgraduate should learn and how they should learn it, there are no fixed guidelines. So even the teachers are finding it more and more difficult, and surgical training of postgraduates is becoming more and more challenging. As sir said, even your camp patients have their own demands. So you cannot consider an eye to be an experimental eye anymore. So you have to be well versed when you get into your OT with all your skills beforehand itself. So your appropriate, as per your first year, second year, third year, there are certain skills that you can master every year, so that when you pass out, you can be a competent surgical ophthalmologist. So what we used to consider earlier was the Halstead's methodology. So this means that intense repetitive procedures under supervision of a qualified surgeon will make you a qualified surgeon. That means every postgraduate was known to perform a predetermined number of procedures. As you can see there, the cat is repeatedly performing the procedure under supervision. But does it mean the cat is a competent surgeon? No. So it is not only the numbers that matter. It's not the quantity, but the quality. So every case should be a learning experience. The mistakes that you do in your previous cases, you should work upon them and try to improve. So as you know, the number of cases are falling short. Every case should be a learning experience for you. So there are several modules that describe what a passive learning is and what compared to an active learning. What is passive learning? Passive learning is how an undergraduate would view the ophthalmic surgery. So there is no structured engagement. There are no specific learning objectives. As a postgraduate, your learning should be active. So it should include asking questions, having guidelines, guided observation tools, engaging yourself in briefing, debriefing, and thereby acquiring your skills. So the NMC has given several guidelines, and the MEU these days, just like in other surgeries, so these sound very complicated: flipped operation room techniques, progressive involvement in procedural skills, engaging students, all of these. So I've tried to simplify this and have put it across as to how I would like my postgraduates, or how we were trained as postgraduates. So you should start getting involved with the patient right from the planning. So what can you do? So as a postgraduate entering the OT for the first time, first of all, you should plan what kind of procedure you're going to watch, what procedure you're going to learn on that day. What are the instruments that you would require and how to handle? Very, very important, how to handle, because you do not want to go into the OT and waste time trying to hold those instruments or trying to manage the handling of those instruments. All the sterilization techniques that go into it, how to position your patient in the operation theatre, how your assistants should be positioned in the operation theatre. The skin sterilization, dressing and closure, all this should be planned well in advance. Followed by deciding the venue. Now, if you have a chalazion, probably, you would want to do it in the OPD. You wouldn't want the patient to be taken to OT. Similarly, there are certain procedures like your intraocular procedures which have to be done in the OT. So a postgraduate should know what are the procedures that can be done in the OPD, what are the procedures that you have to take the patient to the OT. Knowing how to drape your gown, wearing your scrubs, your sterile gloves, okay, and how to go about all of this should be learnt well in advance. The third thing is reading a standardized procedure book before you get into the OT. So all variations, all techniques involved in that procedure, the pros and cons of different techniques, if you're thorough with, then life becomes very easy in the OT. Also read about the complications that you may possibly encounter, as well as get involved in the consent taking and the details of the consent. The next would be how to go about observing the OT or observing the steps in the OT. Again, keep all the, once you're in the OT, keep all the prerequisites ready. For example, how the sister sets up the table for you. Watch, because it should not be that, once you pass out, you do not know. Many a times we have a high turnover of nurses in the OT or OT assistants. So every time you encounter a new nurse or a new OT assistant, it shouldn't be that she tells you what to do. Most of the times you should know where the instruments, how to set up the phaco machine, how to connect the probes. All of this should be learnt during your post-graduation itself. So meticulous step-by-step observation and registration of the steps, as well as following up. So we have OR screens or the side view mirrors where you can actively get involved in the procedure. Sir has already elaborately spoken about wet lab discussions and workshop. Take active participation, because the more number of wet lab cases you perform, the more competent you are and the less nervous you are when you are doing it on the patient yourself. So get a clear perspective of how you should go about. So that's why you need to practice a little bit of skills in the wet lab. So it could be either knowing your IPD, interpupillary distance, know how the optics of the microscope, how the foot pedal works, how you can focus, how you can change the depth, you know, and then also practice other things like tying the knot. Nowadays, of course, we do not do much of suturing, but you never know when your tunnel goes deep or superficial, when you have a wound leak at the end of surgery, it is a must that you should know basic suturing techniques, okay? Get hold of, as sir said, nucleated eyes, enucleated eyes, etc. to do your practice. And of course, you have wax size, and being persistent and consistent is the key, finally, to end up having good surgical hands as we describe it today. So for undergraduates, I think in the first year, even doing small steps like peritomy, you know, cauterization, removal of the lens, closure, these things mean a lot. So start off doing those procedures in your first year so that gradually by the end of your second year and final year, you will be able to perform independent surgeries. Do not panic when you see bleeding from the surgical site. So all of this are important to make your OR time valuable and meaningful. So then you move on to performing the procedure under supervision. So get involved with the patient right from the start. When the surgeon counsels the patient, make sure you're around. Get involved in the pre-operative workup, you know, getting to know the IOL power, the differences in the different types of IOL. All this should come during your postgraduate training itself. Follow standard protocols, and most importantly, stop when you're in doubt. Okay, in the surgery, you know, in ophthalmic surgeries, there is no second chance. So you cannot go to the point where you have no return. So stop. When you know something is going wrong, call your superiors. I'm sure there's nobody who will say no to help you out. And of course, also stress on documentation, post-operative notes, post-operative orders, all of this should be stressed upon. And finally, you go on to independently operating on the patient. So select simple cases in the beginning, maybe a well-dilated pupil, a lesser grade of cataract, a very cooperative patient. This is very important to make your life easier when you're starting off. So keep in mind, always there is scope for learning. So see how every case you can improve when compared to your previous cases. Maintain a logbook. All of this is going to help you in the long run. So with this, I would like to conclude, but there are a few things that, you know, you have to learn as a postgraduate itself, because it will help you as a ophthalmologist in the long run. That is developing professionalism right from the beginning. Know how to talk to the patient. Okay, develop your ethical skills, your communication skills, which I feel is lacking in today's generation. You know, try to do that as and when you all are postgraduates itself. And all of this, along with your knowledge of medicine, I'm sure will help you go a long way. So all the best in your surgical journey. Thank you.
Thank you, Dr. Sarita. You've proved even when we think we're just passing instruments, we're actually picking up surgical wisdom one gesture at a time. May I request Dr. Nikita to kindly present the token of appreciation to Dr. Sarita. Sterilization is not just a routine, but the foundation of every successful operation. To remind us of these non-negotiable basics, I invite Dr. Naya Natarajan to share her insights on sterilization protocols.
Yeah, good morning, everybody. Sterilization is a very often neglected topic, not just in PG education, but with most surgeons as well, because it's considered to be very boring. So I have the less envious task of making it interesting today. So this is a picture that you don't want to see on day one post-op of an eye which you have operated, right? And many of us cannot forget the first endophthalmitis that we've ever had. We sometimes don't even remember the name of those patients. So a million things could have gone wrong. Maybe the patient had an infected lacrimal sac. The OT sister didn't scrub her hands properly. The sterilization of the instruments was incomplete. Sometimes the air in the OT is not sterile enough. But finally, the responsibility lies with the operating surgeon, period, right? So this is a picture of Ernst von Bergmann in 1891 when he used the autoclave for sterilization for the first time. Now, 100 years down the line, we are not fully sure about asepsis and sterilization still. And this can be because of two reasons. One is ignorance. Science doesn't give us the knowledge completely. And number two is ineptitude, where the knowledge exists, but we fail to use it correctly. So there are two ways or two things that come to our aid here. One is standardization of protocol, and the other is checklists. And I cannot overemphasize the need for these two things in our OT sterilization. And finally, a surgeon himself or herself cannot do everything by themselves. It is a teamwork, and OT sterility is built on trust. So these are the two documents that I would definitely advise every surgeon who's embarking on surgery to read about sterilization. The Center for Disease Control came up with this guideline for disinfection and sterilization in healthcare facilities in 2008, which was recently updated in June 2024, which gives you a complete account of sterilization. And there's another one on guidelines for management of cataract in India, which tells you about, which gives you a sterilization module on cataract surgery. So please do read this for a complete knowledge of it. I'm just going to talk about a few things. Before we go into it, the basic terminology about cleaning. So what is cleaning? Cleaning is the removal of foreign material from objects. It is normally accomplished using water with detergents or enzymatic products. After cleaning comes disinfection or sterilization. Now, disinfection is a process of killing all the pathogenic microorganisms from the surface using chemical compounds like alcohol. But you have to remember that they do not kill the spores. Whereas sterilization is the process of eliminating all the pathogenic microorganisms and spores using primarily heat or steam. Now today we'll be talking on certain things, what a surgeon, as a surgeon, can do to take care of sterilization. So we'll be talking about protocols for operating room sterilization, sterilization of instruments, aseptic protocols for staff and surgeon, and what will you do to monitor and surveil the sterilization procedures. Protocols for investigations and management in a case of endophthalmitis is beyond the purview of this talk, and I will not be talking on that. So a basic idea about the OT layout is essential, and this is because you need to know what are the sterile areas in the OT and what are the unsterile areas in the OT. As much as possible, these two should not cross over, and even the surgeon's entry and the patient's entry should be through different doors. The dirty utility and the clean equipment coming in also should be through different routes. Again, inside the OT, once you are gowned and gloved and scrubbed, gowned and gloved, you should move to the sterile area of the OT, which is the further end, towards the head end of the patient, and you need to remain there throughout when you're performing the procedures. There should be no loitering on the foot end of the patient, which is considered to be the unsterile zone, where the observers and the other people move around in the OT. Now coming to ventilation, many of the OTs are fitted with HVAC systems. But some OTs do have split ACs. Again, they need to be cleaned every month. But what you need to observe here is whether the temperature should be maintained between 20 to 23 degrees Celsius and a relative humidity of around 30 to 60%. And about 15 air changes per hour need to be done. A basic idea, you would have seen all these colored bins in the OT and you don't know which one, what goes into what. Most of the times the sister will tell you, okay, throw it in the red bin, throw it in the yellow bin. But you need to have an idea, a basic idea of where what goes. So where your gloves go, where your soil linen go and all that. So coming to sterilization of instruments, which is the most important. Basically, whatever touches the eye is what is most liable to cause infection. which will be your instruments. The second thing will be whatever goes inside the eye. That will be your viscoelastic or your BSS. Now, for this, you depend on your pharma companies. You have to trust your pharma companies. There's no other way around that. And finally, or the least probably, is the sterile air in the OT, which is not of much concern. But yes, it is also important. Now, coming to the instrument cleaning, the first thing is cleaning before going in for sterilization. So cleaning is usually done with the help of an ultrasonic cleaner, in which an enzymatic removal agent is applied, or an equally effective method which is used in most OTs is the 4-bowl method, where 4 bowls are taken with distilled water, and in the first bowl, a cleaning agent is applied and your instruments are soaked to remove the blood and other debris. And you have to remember that even the cannulated instruments have to be flushed, basically flushed to remove any visco residues or anything. And then it has to be dipped into the other 3 bowls and completely cleaned of any soap residues before it goes into drying and packing. And then finally it goes into sterilization. So autoclaving or steam sterilization is what is commonly used. Of course, it is the most economical. It can be used to sterilize most of the instruments that we use in the OT. It is completely sporicidal and it is not associated with any reactions like TAS. Now, to make sure that the sterilization is complete, we place indicator tapes, which are placed on, I'll be talking a little more in detail when it comes to chemical indicators. They are placed in the bottom, middle, and top of every drum, and the duty of the operating surgeon is to check and sign before you even start your first case in the morning of the surgery. So just for completion's sake, these are gravity-dependent autoclaves. Most of the OTs have these horizontal autoclaves or the vertical autoclaves. Basically, what is done is steam is put into the, pumped into the chamber, which will push the air out. So it takes some time for the air to completely come out. And then a temperature of around 121 degrees Celsius is achieved for about 30 minutes at 20 psi. So this is the usual steam sterilization that is done. You have a quicker way of doing it, and this is called as a B-class autoclave. The only additional thing that it has a pre-vacuum setting. So it will remove all the air automatically. So obviously the autoclave time comes down to around 4 to 5 minutes, which is much more easier. When you have to do sterilization between the surgeries, that is, you have an instrument which you need to reuse, you don't have enough sets, then you go for what is called as a flash autoclave. Now, flash autoclave has a cassette basically like this, so all the instruments don't have to be wrapped, only cleaned and dried and put in this, and then in 7 to 8 minutes your sterilization will be done. Now, coming to ETO or ethylene oxide sterilization, this is done usually once a month or twice a month in most OTs. Those instruments which have wires on them, like your diathermy probes or cryoprobes, these are the instruments which can be autoclaved with ETO sterilization. So the instruments are packed in special polythene bags with indicators inside. And you have to remember that this ETO gas is very toxic. So aeration period of minimum 72 hours should be there before you use these instruments. So the thing to remember here is that autoclaving in drums or linen, the shelf life is just 48 hours. Whereas if you autoclave with double packing, like in a B-class autoclave, then you can keep it for around 28 days. And ETO sterilization with a double packing usually can be kept for a year. Now, this is what I would like to stress today, aseptic protocols for the staff and surgeon. So, separate OT scrubs in the OT. No scrubs that are used in the OPD or anywhere else should be used in the OT. No street clothes, and of course, no wearing warmers inside because woolens will attract microorganisms. Well-fitting scrubs, no flapping, and you should have dedicated OT slippers or shoe covers. While wearing the cap and the mask, the cap needs to cover all your hair completely, and the mask needs to cover your mouth and your nose also completely. Decontamination of hands is a very important way of stopping infection from happening. So the scrub time should be minimum of 5 minutes. The first wash should be with soap, and the second and third wash with an antimicrobial solution like povidone 10% or chlorhexidine 4%. The areas in red that are marked over there are probably the areas that will be most missed when you're doing a scrubbing. So this kind of a chart should be ideally put up And please, most of the OTs have that next to your scrub area. You need to keep looking at them and make sure that you don't miss any of those areas and scrub all the parts. And you should remember that your hand is the most sterile part. Okay, so your fingers and your hand are the most sterile part. Everything else is less sterile. Up to your elbows is less sterile. So, another thing, after scrubbing again, when the water is poured, again it has to go from the most sterile area, which is your hand, down up till your elbow, not the other way around. So that is important. So make sure you take it out of the stream of water and then again, go ahead and wash. This is a video of gowning. So again, in gowning, it's very important that you push your hands both into that and not pull it like this. That's wrong. Okay, so your bare hands, ideally, after you go into the gown, should not be touching anywhere else. You just pull it, and most of them have elastics here, so you can easily pull it and it won't come down. And you have to remember that anything below the waist and behind you is completely unsterile, is considered unsterile. So as soon as you finish gowning, you need to put your hands up and hold it in this praying mantis position and not let it loose or hang down. Again, donning gloves. After I finished undergraduation and in post-graduation, I remember when I was wearing gloves, one of my professors asked me to, he saw me wearing the glove and he asked me to wear it again. So I had to, take it out and again wear it. I did it 3 times to get it right. So I will never forget how this is done. So when you put the first glove in, you're using your bare hands to put it in, right? I'll show you this again. So you're using your bare hands to pick up the glove. You're putting your first glove inside. So you're holding the inner surface of the glove and not the outer surface. You're not touching the outer surface of the glove. So once you pull it in over your band there, you'll use the sterile part of your left hand glove now to hold the outer part of the glove. You're not touching the inner part of the glove again. You will go in and you will pull it, so you're nowhere touching the inner part of the glove here. And you will pull out the other side. Again, you're touching only the outer side here. So this is the correct way to wear your gloves. Again, removing gloves is again important. The outer part is now completely, you've got blood, you've got everything, so please don't touch anything. You need to make sure that you remove one of the gloves holding from inside, hold it in the other hand, and then pull the other one out and throw and wash. So during surgery, you need to double check orally the sterility of the opened consumables. Most of the times, the date is written, so you need to confirm once before using the instrument. And if there is an accidental touch, by chance you touch something that is unsterile, don't be scared of the sister. Please tell them, don't hesitate to change your gloves. And if there's a need to cough, please turn away from the operating area and cough. Now, between cases, this is a very nice way of, waiting, but this is absolutely wrong because your elbows, again, are considered unsterile. So please don't stand like this. You change your gloves and you hold your hands in praying mantis position and stay in the sterile zone, and there should be no loitering. For observers in OT, hands are kept, these are some of the rules that we follow. Hands are kept together away from any equipment. Leaning or crossing or touching over the sterile fields is not done. And 1 foot clearance from the sterile area should be strictly observed. And excessive coughing or sneezing inside the OT should be avoided. But nowadays, with these days of 3D microscopes and other things, it becomes very easy. You just wear a 3D glass and then you can stand very well away from the sterile field and watch everything in detail. So coming to monitoring and surveillance, the last part of the talk, surveillance of sterilization procedures. This is what most of us neglect. We don't know much about it maybe, most of us neglect this. So there are air conditioning units and HEPA filters which need to be checked routinely. Water samples need to be taken and tested. OT culture needs to be done periodically. Autoclave and ETO has to be validated regularly. Now all these dates ideally should be displayed prominently outside the OT somewhere on a board for everyone to see. So even before you enter the OT, it is better to have a look at it and make sure that you're going into a validated OT before you start the OT. And OT swabs ideally should be sent for biological testing every month. They should be taken from both sterile and unsterile surfaces. So the floor, the OT surfaces, wall, AC unit, everything. Air samples also need to be checked by an open dish sedimentation method. And again, the due date needs to be noted and displayed. So coming to sterilization, validation and indicators, this is called as the Bovie-Dick test. It is used to detect inadequate air removal or air leak inside the sterilizer. So this is a set of towels which are like 100% pre-conditioned towels which are placed inside the OT, and about 3 minutes inside the sterilizer, the autoclave, and the autoclave is run for about 3 to 4 minutes, and if it shows a uniform color change, then it is good to go. This ideally needs to be done before using the sterilizer every day, but generally not done. Usually weekly once this is done, the Bovie-Dick test is done. Coming to chemical indicators. Now this is what you generally see on the bins. So the chemical indicators are of 5 classes, but what we generally use are the class 1 and the class 5 indicators. Now class 1 is a process indicator. It will only tell you whether the unit has been exposed to the sterilization process, nothing else. Whereas a class 5 indicator will tell you whether all the variables like temperature, pressure, time have been achieved, and they can be counted equivalent to biological indicators which are the gold standard of sterilization. So this is a class 1 indicator. You can see on the top picture that it is not yet done, and then there is a color change down, so it is done. So it has been exposed to the sterilization process, but it does not give you any idea about the biological load. So class 5 indicators which are placed inside the bin, inside the set are more important, and they should be removed and dated after sterilization and displayed in the logbook, and the surgeon needs to look at this and sign before the first case of the day. Biological indicators are used both for autoclave and for ETO sterilization. Now these use the spores of bacillus basically, and if nowadays you have these rapid readout ones where there's a color change immediately and you know that the spores have been killed. So this is what has to be done every fortnight, and the results must be documented. This gives you a better idea that the sterilization apparatus is working correctly. Now when it comes to when you have an endophthalmitis, it should be ideally told to an infection. Immediately, an infection control committee has to take care of it, which is a team comprising of the ophthalmologist, the nurse in charge of the OR, the hospital manager, and the lab in charge. So in case of an infection, it is brought to their notice immediately, and immediate investigation and a complete repeat validation of sterilization procedures before restarting the OT has to be done. So the take-home message is that sterilization practices need to be practiced meticulously. The SOPs, the standardization of protocols and checklists, will form a very important part, and teamwork and understanding each member's role is very, very important. Thank you.
Thank you, Dr. Meyer, for reinforcing that checklist. It is a culture of safety for every surgeon. May I now Dr. to the center token of So the session is open for discussion. If anyone has any questions, they can ask. So we'll soon be having the inauguration. In the meanwhile, I'll start the next session. No one is... Okay. Okay, I'm sorry. Sorry for the delay. No one is born knowing how to tie a perfect surgical knot, and thankfully, no one expects us to. Stepwise training is what turns our shaky first attempts into smooth, confident moves. To talk about building confidence before competence, I am delighted to invite Dr. Sheetal Savar to the stage.
Good morning, everybody, and thank you for this opportunity. So I will begin with this topic. Perhaps it's a bit of overlap between the other topics that were there in the morning. So it kind of might seem like a summary to all of you. How do I change the slide? This one, right? Okay. Yeah. So like Sarita said, you know, the PGs in ophthalmology, after a great battle, would have cleared their NEET and landed in their dream specialty, hopefully. And after this, you know, it's like hands are itching to operate, and they've gone for a very long distance camp, seen so many patients. One of them will be Mr. Duja Pujari, okay, who's blind as a bat. And the unfortunate part is he's lost many members of his family in some bus accident, and it's only his little grandson who's there with him. Okay, so this PG manages to convince him and bring him for surgery, you know, one of the camps. Now this is the postgraduate who's very happy that the patient has landed in his hospital, and he's like drooling and waiting to operate. He's dreaming that next day he's going to get a full case. Okay. But this is the teacher, okay, in a dilemma because this PG is working hard, yes, convinced and got the case, but he's not been doing his wet labs. He's not seen him suture, so he's not very sure. And he also knows that adults with blindness have 1/3 shorter life. That means if Duja Pujari was to live for 90, he might only live up to 60 if there was a complication of this surgery and he landed in blindness. Also, young children drop out of school many times in, in many smaller places to care for the blind. Oh, I did something, yeah. Now let's look at another perspective. Okay, this is for the PG. Imagine you are the patient and you are your own surgeon. Would you want to operate? What kind of competence would you expect a surgeon to possess? Can you achieve that level of competence? So let me just here describe to you what competence means. Surgical competence is the ability to apply knowledge, skills, and professional attitudes effectively and consistently to perform surgical tasks and manage patients in both familiar and new situations, leading to acceptable clinical outcomes. So, acceptable clinical outcome, please remember that. So how should one go about this is perhaps been covered. You have to read books and not small guides. You have to read the most descriptive book for surgery. Then of course there's no dearth of online material. There are online videos. Some of, I've put up, very good lectures are there. Then there are some websites like CyberSite. So there's no dearth of material. Next is to understand the tools. Okay, so as in the earlier talks it was mentioned, it's not okay to just go and operate. You have to know how your microscope works. Many times I realize my PGs, they don't know how to zoom, they don't know how to focus, but they all want to operate. Okay, also you must know which instrument is, for which step. The surgeon should not be asking you, give me this, give me that. And you should know how each surgeon wants his instruments. Also, asepsis and the correct scrubbing technique, that also one has to concentrate on. Next is to understand the mechanics. So again, this was described, you have to watch and observe very actively. You observe many senior surgeons performing because each one has a different approach. Okay, and you never know what might be useful to you later. So observe all this and also understand the surgical process and how surgical teams work. Now nothing is ever too small in surgery. So some of these things I'm telling you is what our PGs have done in our institutions right from COVID days. Until then, wet lab was not so active. Okay, after that, we all got desperate to teach them and they were also desperate to learn. So we actually started with all this. We have tried so many different vegetables and fruits. So some of the steps that you can practice is making an incision. You can do a tunnel. You can practice capsulorhexis. So you blanch a tomato, half boil a potato. You can use an apple, you can use a plum, you can use a grape. So there is no end to it. Just be innovative. You can use anything to practice. And surgery is a craft. So working on the skill really helps. This has also been spoken about. So we started with any eye that we got, goat's eye, porcine eye. And we started like this. These are our pictures during COVID time. And we didn't really have artificial eyes at that point in time, but they're also available now. Then we were innovating and we started using smartphone magnification so that they can use both their hands. Then we started using the surgical loop. Some of our PGs you may recognize. Then we started using the microscope also. So now you would ask, are they really useful? Yes, there are studies to show. One of them done in India says, there's a 52% reduction in PCR rates when trainees underwent skill training in the wet lab. Also, there's a randomized control trial that showed using synthetic eyes for simulation training in SICS doubled the confidence of trainees and reduced complication by 72%. So there is enough proof if someone wants to know. Okay, this I'm not showing because everyone has been showing this picture. So we know that simulation is very important. Perhaps we are going to get one of them in our neighboring colleges soon. Okay. So the advantages also has been described, you know exactly the depth of the dissection plane, IOP, angulation, the machine is going to tell you good, bad, you can do it any number of times, so I won't spend too much time here. So the advantage again is the trainee can assess their own competence, and if there's a feedback from the trainer, it's even better. They can really focus on where they're lacking. Now this is coming to my core topic, so I thought I'll add something here. This is all about cataract. Maybe there are some simulations maybe for vitrectomy also. But what about other procedures? There's so many things you're doing. Lid tear repairs, entropion, ectropion, DCR, squint. Where the hell are you going to learn this? Okay, so till we have better simulations for the other, this thing, I'd like to tell you that we have something called as fresh frozen cadaveric dissection. Okay, you might wonder how this is different from the cadavers we used in the anatomy lab. So those are preserved in formalin. They are so shriveled, the tissue loses its original feel. Also, there are embalmed cadavers, but what I'm talking about and what we have in our institution is fresh frozen cadavers. So that is next best to operating on a live person. So this is how it is stored. It's a deep freezer. It is the body immediately after death. Nothing is done to it. Okay, it is just stored at minus 20 degrees centigrade. And before we use it, it has to be thawed for 3 days at 4 degrees centigrade. And this is how we plan our module. We've been doing this for 3 years. So initially, when we get the date for our Ascend lab, we plan all the surgeries. Around 25 surgeries we perform on one cadaver, and we are given only 1 day, so we really maximize our resources. So the training starts a couple of weeks before, wherein both the anatomy and the surgical procedure is discussed. So there is peer learning and there is a facilitator also, faculty who discusses. We touch each and every aspect again. We again go through sterilization. We go through arranging the trolley and the various instruments that are used. Then in the module 2, we make them do wet lab for all this all over again. And then finally, this is the advanced surgical skill lab. Okay, so here, we mimic the actual OT, so you can see everybody in scrubs, etc. And before this, what we do is we give them a checklist of the common surgeries they are going to perform. Each PG performs at least 5 procedures. So we tell them, this is how we are going to evaluate you. They go through this checklist beforehand. And like I was mentioning, just see the kind of procedures we are able to do on a cadaver. Lid tear, tarsorrhaphy, ptosis. Recently, I marked this in red because even orbitotomies we did in the skill lab, and we were actually able to perform, we removed an orbital mass after this. This is what the faculty did. So that is the kind of exposure. And the next picture you will see, this is the LPS. Okay. So can you see how clearly we can make out the tissues? It is literally like operating on a live patient. So you see hooking of the muscles here, and lateral rectus recession, lateral canthotomy. So, and after this, what we do is, during the procedure, the faculty will evaluate the students while they perform. Then at the end of it, we take a feedback from the student, because each year we want to improve. We want to know, how we can improve on this. And after this, when the PG actually gets cases, they may be small cases like DCT or chalazion, but we assess them stepwise because they've been trained stepwise earlier. So here are some more tips that I'd like to give. So many times in the OT, what happens is everybody, especially the PG, is focused on getting the whole case. So please don't do that. So you focus completely on one step at a time, getting it right. Then I also wish to say that you must learn from the best. The more skilled the surgeon is, the more senior he is, actually you should learn from them. Make them, request them to assist you. And always use good microscopes and good instruments, otherwise it will bring down your confidence. If you can't see, you think you're at fault, you think you're not a good surgeon. But beginners need good instruments. Always do your best to record your surgeries, go through them multiple times, and it's very, very important to reflect. Now, this is something we follow for our postgraduates. There is a reflection form given to them after every case they do, no matter how small a step. So they will say what went right, what went wrong, and whoever is assisting them will give them marks for each and every step they have done. Then they'll go back, read, and work on it. And this is usually discussed before their next case, so they don't make the same mistake again. Again, a very important point is PGs should choose an ideal case. And what I mean by ideal is the vision in the other eye should be good, and the ocular exposure should be good. You don't want very prominent brows and then struggling, or a very small eye and the PG struggling. Also choose the grade of cataract. Don't go for a very hard cataract, because nucleus delivery may become difficult and you may damage the cornea. So pupils should dilate well, and things like ability of the patient to lie down for a long time, and also would be very helpful if you know the language of the patient. It makes a huge difference for the patient to cooperate, when things are a little shaky. Then also there are rubrics, okay? So to ensure that beginners meet a certain standard of performance, a standardized internationally valid tool such as the ICU Ophthalmology Surgical Competency Assessment rubric is useful. So during your sim also you can use, and perhaps you can also do the same, you can assess the student when he's doing the actual steps, so that you know whether he's a novice, is a beginner, or he's competent, and accordingly you can give him more steps and more independent cases. Okay, so this is what it appears like. I would request the teachers to go through this and try to train your PGs in this fashion. So as it was mentioned earlier, it's also important to have a good physique and posture for extended work hours. Very important that you must have passion for learning and to help patients. And I would love to stress, okay, on this point, you have to learn to endure failures. We can't have great days always. And most of us get very disheartened when we have a failure. So I think it's important to train them how to endure failures. And I would say many times you need prayer, not sometimes. And also to develop a good clinical judgment. It's not a very easy thing. So as Lord Smith, who was the past president of Royal College of Surgeons of England, once put it, it would take me 1 year to teach a trainee how to do an operation, 5 years to teach them when to do the operation, but a lifetime to teach them when not to do an operation. And I think it's a very important thing. We should know, especially in the beginning of our career, what not to touch. So how much is actually good enough? Okay. So in one paper that I came across, they said in UK, they insist that the residents must do 350 surgeries before completing residency. In US, they say it should be at least 86, okay, independent surgeries. And in India, they say it's good to have 50 phaco's and 50 SICS, but there's no minimum mandated number. Maybe this is something that we should work on. Training must be more proactive, but at the same time, we have to remember that it has to be self-directed and reflective, because it's all about learning. Nowadays, what we do is teaching. It has to be more of learning. That means the student has to feel the need. And again, this quote I really like because it makes a lot of sense. Under pressure, we don't rise to the level of our expectations. We fall to the level of our training, and that is why your training has to be solid. So coming back to Mr. Duja Pujari, so if the postgraduate, without having done his wet lab, his studying the procedure, not keeping the sterility measures, goes ahead and operates, so Duja Pujari will always remain blind, and his grandson will have to discontinue his school. Because remember, I told you that mishap where he lost all the members of his family. So if the grandson stays back to look after him, there's no school for him. So with this, I hope I've given you some tips for building confidence before competence. It was more like chicken or egg of a thing for me. But since the topic was confidence before competence, I thought this is the best way I could put it. So thank you once again for giving me this opportunity. Happy teaching and learning. Thank you.
Thank you, Dr. Sheetal. Now we know it's okay to be clumsy at first, as long as we keep taking the next step towards becoming surgeons. May I now request Dr. Devika to present to Dr. Sheetal. Can we please have Dr. Sheetal ma'am on the stage, please?
Good morning, respected dignitaries, esteemed faculty members, and dear delegates. On behalf of the Department of Ophthalmology, it gives me immense pleasure to welcome you all to the inaugural ceremony of our CME, Postgraduate Surgical Training, The Way Forward. As the saying goes, education is not the filling of a pail, but the lighting of a fire. Today, through this CME, we light the fire of knowledge, skills, and innovation that will guide our postgraduate delegates and future surgeons. To begin the proceedings, may I take the privilege of inviting the dignitaries onto the dais. Our respected Vice President, Shri PRASHANTH Shetty Sir, our esteemed Dean, Dr. ASHOK HEGDE, Associate Dean, Dr. SUSHITH, Chairman of Scientific Committee, Karnataka Ophthalmic Society, Dr. Jain, Head of Department of Ophthalmology, Dr. Kuntikana, and our organizing secretaries, Dr. AJAY KUDVA and Dr. AKANSHA Shetty. I request you all to kindly join us on stage. I request you all to kindly stand up for the prayer.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada. Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada.
I would now like to invite all the dignitaries on the dais to kindly proceed with the lighting of the lamp, a symbol of wisdom, hope, and learning. May I now invite Dr. Rajani Kadri, Professor and Head, Department of Ophthalmology, to extend a floral welcome to our distinguished guests. Thank you so much, ma'am, for your warm and kind welcome. I now request our Dean, Dr. ASHOK HEGDE, to kindly address the gathering.
Respected Vice President of Lakshmi Memorial Education Trust, Shri PRASHANTH Shetty, Vikram Jain, Scientific Advisor, Scientific Committee of Karnataka Ophthalmic Society, and other dignitaries on the dais, and my dear delegates. Good morning to one and all. I consider it as an absolute honor and privilege to stand before you today as we inaugurate today's CME organized by Ophthalmology Department of our institution in association with the Karnataka Ophthalmic Society and South Canara Ophthalmic Society. I take this opportunity to congratulate the Department of Ophthalmology, Dr. RAJANI, Professor, Head of the Department and Organizing Chairperson, Dr. AJAY KUDVA, Professor, Organizing Secretary and President of South Canara Ophthalmic Society, Dr. AKANSHA, Organizing Secretary, and all my esteemed colleagues in the Department of Ophthalmology for organizing this meaningful CME and workshop. Our beloved President, Dr. AJAY Shetty, and our Vice President, Shri PRASHANTH Shetty, they are always in the forefront to support this kind of academic activities across all the specialties in our institution. In the changing landscape of medical science, ophthalmology stands out as a specialty, beautifully combining fine surgical skill with the cutting-edge technology. I am sure today's CME and workshop has been organized taking into consideration and mainly focusing on practical aspects of hands-on training, which is something absolutely crucial to develop confidence and surgical finesse. I urge all the delegates to take part in this workshop and CME actively, ask questions, push to your limits, and practice on simulators so that more and more you do, more and more perfect you'll become and you'll become experts. This workshop not only is going to enhance your technical skills, but also your deep commitment towards the noble cause of giving sight to others. I take this opportunity to wish this CME a grand success. Let it be very fruitful and enriching experience to all the delegates. Thank you one and all.
I would now like to call upon our Vice President to speak a few words.
Good morning. Dr. ASHOK HEGDE, Dean, Dr. Vikram Jain, and other dignitaries on the dais. Firstly, I'm happy that the Department of Ophthalmology has organized today's CME on postgraduate surgical training. I think this program will provide excellent opportunity to postgraduates to strengthen their skills and to update the advanced skill. I think through the guidance of today's speakers. I thank the speakers for accepting our invitation and being part of this program. Finally, I want to thank the HOD, Dr. RAJANI, and his faculty members for organizing this CME and wish them a great success. Thank you.
Thank you very much, sir. Next, I take great pleasure in inviting the Chairman, Scientific Committee of the Karnataka Ophthalmic Society, Dr. Vikram Jain, to share his thoughts with us.
Good morning, Vice President Mr. PRASHANTH Shetty sir, Dean Dr. ASHOK HEGDE, Vice Dean Dr. SUSHITH, members from faculty, Department of Ophthalmology. Surgical training is a very nice topic for the CME that they have chosen, and in the earlier days we didn't have much access to online tools. Dr. Sheetal has just pointed out that right now there is no dearth of knowledge for this, but what to choose from becomes difficult when there is so much of choice. Ma'am has already given a few pointers. All faculty today are faculty extraordinaire. I hope that all students out here pick up a lot from the faculty today. Very happy that two people who helped me in my initial days of surgical training are here today. Dr. Yogesh Kamath, who helped me with my baby steps of surgical training, and Dr. AJAY KUDVA, who I would call every evening. He was doing his fellowship back then, every evening to discuss what happened in my case and all that. So not only online tools, you need to have a good connect with your peers also and discuss what went wrong, what went right. Make sure that you take most from the teachers and faculty today. All the best to the department for the CME.
Thank you, sir, for your insightful and motivating words. I would now like to call upon Dr. Rajani, our HOD, to speak a few words.
Good morning and a warm welcome to one and all present at this inaugural function. On behalf of the Department of Ophthalmology, AJAY Institute of Medical Science and Research Center, and in the proud association with Karnataka Ophthalmic Society and South Canara Ophthalmic Society, I extend a sincere and heartfelt welcome to this CME program dedicated to postgraduate surgical training. It gives me immense pleasure to acknowledge and welcome our distinguished Vice President Shri PRASHANTH Shetty, whose vision and leadership continue to inspire excellence in our institution. Thank you for those kind words, sir. We are honored by the presence of our respected Dean, Dr. ASHOK HEGDE, and Associate Dean, Dr. SUSHITH, whose dedication to academic and clinical excellence forms the bedrock of our success. A very warm welcome to Dr. Vikram Jain, Chairman of Scientific Committee, Karnataka Ophthalmic Society. His dedication to clinical research and teaching continues to uplift the ophthalmology practice across Karnataka. Thank you, Dr. Vikram. We extend a special welcome to all delegates who have joined us for this academic event. Our organizing team has worked together to bring an impressive program that spans modern training modalities, simulation, and hands-on skill development. This CME shall be a memorable journey of knowledge sharing and innovation as we work together to advance postgraduate surgical training. Thank you and welcome once again to each one of you.
Thank you, ma'am, for the graceful welcome. We now come to the concluding part of the inaugural function. I would like to invite AKANSHA Shetty, Organizing Secretary, to deliver the vote of thanks.
Good morning, everyone. It is indeed a great privilege and pleasure to deliver the vote of thanks on this special occasion of the CME on postgraduate surgical training, the way forward. On behalf of the organizing committee, I express our heartfelt gratitude to each one of you for your active participation and making this event a grand success. First and foremost, I would like to extend our sincere thanks to our Vice President, Shri PRASHANTH Shetty sir, for gracing the occasion and giving us unconditional support to our department and the CME. We are also thankful to our esteemed patrons, Dr. AJAY Shetty, Srimati SHARADA J Shetty, Srimati ASHRITHA P Shetty, Dr. PRASHANTH MARLA and Dr. AMITHA P MARLA for their unwavering support and encouragement towards our academic endeavors. Special thanks to Dr. Ashok Hegde, our Dean, Dr. SUSHITH, our Associate Dean, for their continued support towards the academic growth of our department and institution. I would like to thank Dr. Vikram Jain, Chairman Scientific Committee, Karnataka Ophthalmic Society, for accepting our invitation and gracing the occasion. I would like to thank Dr. Rajani K, our Professor and HOD, and Chairman of this event, for her constant guidance, valuable support, and encouragement that made this program possible. Our deepest appreciation goes to Dr. AJAY KUDVA, co-organizing secretary, whose relentless efforts and dedication ensured seamless organization of this academic event. We are extremely grateful to our esteemed speakers who shared their valuable expertise, knowledge, and experience today. Your insightful talks on topics ranging from simulation-based surgical training, sterilization protocols, digital resources, phacoemulsification, and stepwise surgical training have certainly enlightened and empowered our postgraduates. We thank the entire team of Alcon India, Mr. Nishant, Mr. Karthik, and Mr. Sumesh for getting us the Fidelis virtual reality phaco simulator and laureate phaco machine for the wet lab. A special word of thanks to my colleagues Dr. Devika P, Dr. Sharan, and Dr. Nikita for their constant support. A special word of thanks to our technical team, administrative staff, and our postgraduates whose dedication and hard work ensured smooth registration, logistic, and overall organization of the CME. I would like to thank our sponsors, Entot Pharma, Microlabs, Sun Pharma, Oli Pharma, Medicion Pharma, and Sunways for the support they have provided. Finally, to all the delegates, postgraduates, and participants, thank you for the enthusiastic participation and engagement throughout the day. Your presence and active involvement are what make such academic programs worthwhile. We hope that learning from today's session will inspire and empower all of us to strive towards surgical excellence in our professional journey. Thank you once again, and we look forward to more such academic gatherings in the future. Stay safe and have a wonderful day. Thank you.
Thank you, ma'am, for that graceful expression of gratitude. Thank you, ladies and gentlemen. With this, we formally conclude the inaugural function. We will now take a pause for a tea break. May I request everyone to proceed for tea. The second scientific session will begin shortly. had a refreshing tea break. May I get your attention, please? I hope you all had a refreshing tea break. Without further ado, let's begin our second scientific session. I feel truly honored to host our distinguished speakers who will enlighten us with their insights today. In today's world, digital platforms have transformed how we learn and practice. This session highlights how to effectively utilize online resources to enhance surgical training and expand learning beyond physical boundaries. To begin with, may I request Dr. Atul Kamath to kindly grace the dais and share his insights with us.
Good morning, everybody. At the onset, I would like to thank all the organizing members of AJAY Institute of Medical Sciences for giving me this opportunity to speak on at today's CME. And I'm Dr. Atul Kamath, and I'll be talking on online and internet-based surgical training and on to how to maximize this digital resources. So walk in time. So if you go 100 years back, this was how a surgery was taught. You can see that a surgeon is performing on a patient and so many people are just watching it like it's a theater movie, right? Probably the name operation theatre would have come from this particular place where the surgeon is standing, operating on a person, and so many people are just watching it and gaining their experience and trying to learn something from this particular surgery. So then slowly there was a shift to the digital age, probably because of these three things, probably because of technological advancements, globalization of education, and obviously 5 years back, which we had the COVID pandemic, it was an eye-opener for us where we came to realize that digital learning is much more easier and safer to learn when such things occur. So in the traditional surgical training, initially we had this in-person mentorship where you used to apply to a particular doctor, he used to see your CV, he used to look at you, and then he used to call you, you go to him, you work with him, and you gain your experience. Then came the OR experience where you go to the OT, you observe the surgeon operating, and then you gain your experience from those particular places. Finally came the cadaver labs where you used to learn on the cadavers and gain your experience. But the limitations were geographic barriers. You had to go to that particular place, spend time with that particular surgeon and learn. Limited resources and high cost. So then came this online collaborative learning, especially during the COVID-19 times, where global webinars, case discussions, and online conferences started, along with usage of interactive platforms like Zoom, Microsoft Teams, and WebEx. Many conferences went online, like AO webinars, SAGES conferences started going online. So why digital training? Not all surgeries begin with a scalpel, but some begin with a simulation. And the advantages of this would be accessibility across geographies. With the touch of your phone, you can attend a meeting that is going on in the United States. You can click on a link and attend a webinar which is going in Japan. So that's the reason this digital training is advantage. So the accessibility across geographies is taken care of, cost effective and scalable. With a lot of cheap internet packs which you have, with the internet accessibility, it's easy, scalable, and you can get this particular digital training possible. On-demand learning, you need not have a particular fixed time to read. Anytime whenever you are free, your time permits you, you can start learning. Safe environment for skill practice, and you can have a standardized curriculum delivery where it is standardized and you can learn, especially in BMJ and all, British Medical Journal, they have all these particular training programs which you can enroll, listen, and gain your experience. So in the key digital resources, you have these particular platforms. In the e-learning platforms, you have Coursera, Medscape, and Touch Surgery. In the virtual reality and augmented reality, you have the immersive simulation for surgical procedures, video libraries and live streamings on YouTube, WebSurge, and OR Live. And of course, all the websites have now come out with their own apps on Android and iPhone, which are compatible. So you just need to download their apps, keep it updating every time, and you can have a seamless access of all their material. And then artificial intelligence and simulation tools, where personalized learning, error detection and feedback is possible with these particular tools. So in ophthalmology, you have all these particular places, especially the first one is Indian Journal of Ophthalmology. Once upon a time, it was only hard copies which are available. Of late, IGO is gone almost online, and they are asking people to subscribe if you want a hard copy. Otherwise, it's going to be online anymore. The second one is the HEGDE module, which is a simulation module which is conducted by ASHRS, and it is going across the countries or across the European nations, where they're training surgeons or the young ophthalmologists to gain their skills. So that is the HEGDE module which is going on in the second image. Third one is obviously the Alcon Experience Academy, where you have this digital learning series, where it covers a vast series of videos, right from patient counseling, creating a tunnel, steps of the surgery, how to take care of a toric IOL, what are the things that you need to do, IOL biometry, everything is being covered in this particular digital series. And the good part is they keep on adding new videos every time and they keep it updated. And finally is the Asia Pacific Glaucoma Society, which is again has its own popularity, and it has its app where you can download and you can get updated. So the best thing for the residents here would be to enroll and subscribe all these particular platforms, because once you're a resident, everything is free, and they give you a minimum of 3 to 5 years of subscription when you're a resident. The minute you finish your residency and you have a degree, then you have to pay for all these things, and it goes in dollars. So the best time would be in residency when you're a second year or third year. Subscribe, be a part of it. For 5 years, you can have all the accessibility, gain your knowledge, practice, and then you can come out of it. So APGS, ESRS all have 5 years of subscription. The minute you get your degree, your hands are tied, then you can't, you have to pay in dollars especially. So in popular platforms, you have IC Surgical, which are VR-based phaco and vitreoretinal surgical stimulators. Cyberside by Orbis is again one more great place, where there are free online courses. Almost, I think, once in 2 weeks, Cyberside conducts their own webinars. You just need to subscribe. They just need your email ID, right? And they'll give you all the latest webinars which you can observe. Then there is telemonitoring. AAO1 network is one more good place where you have high quality video library and clinical cases. iTube is one more place. It's just like the YouTube of ophthalmology, where all the surgeons just need to have a profile and you can upload your videos on iTube, and it's a good place to learn again. Again, free subscription. iFocus is by AIOS, which you all know and has been discussed in the previous talks. It's an Indian platform for ophthalmic e-learning, and Help Me See, which is a simulation based, which is I think available in few centers across the country, where they give training for SICS. So augmented reality is the next thing that is coming up, where use of AR headsets like Microsoft HoloLens, which are used. And the advantage is overlaying anatomical structures are performed, real-time guidance is being given, and you can do remote proctoring. And the most important is you can practice repeatedly. You don't have a shortage of tissues, nothing like that. You do once, you have not performed it right, you can perform it one more time. And the best thing is it analyzes you and assesses you and gives you a score, whether it is good, bad, or worse. So you keep on repeating till you are perfect in this particular place. Yeah. So the benefits, as I told, repetitive practice, realistic procedural feedback, and measurable progress tracking can be done. And Alcon has come up with this new VR training called Fidelis, which will be gaining today in the afternoon. So this is again a VR simulation, which will be helpful for you in practicing, repeating, and gaining the finesse in this particular place. Now, what are the challenges? So limited access to high-speed internet in low resource areas. In Mangalore, I think you'll be able to get it. Probably go 50 kilometers away from here, you may have some problem with the internet facilities. Technological learning curves. So myself, I'm not sure whether VR, because I have not tried VR, so using a VR, probably I need to get used to it and then train people. So technological learning curves is there. That's the second part. Lack of tactile feedback. Now in VR, you're doing it in the air or probably using the VR automated modules. But when it comes to the real eyes and to the tissues, again, handling could be slightly difficult, so that would be one more disadvantage. And obviously, ethical concerns in patient simulation. So what is the future that we see from here? So as far as I can see, integration of AI-driven tutors would be required, where you have a realistic approach, advances in that realistic field, and blockchain for credentializing and certifications. So once it is certified, you can have a standardized teaching method where if you have created that module or crossed that module, then you are on par with your peers. And hybrid models, this would be more important, where combining online and in-person, because you just can't read from or learn from a robo, nor can you practice directly on patients. So a combined hybrid model where you learn online and then in-person training would be the best approach, is what I feel in the future. So in conclusion, digital tools are enhancing but not replacing the traditional training. Accessibility and scalability are the limitations which, if taken care of, would be of good benefit for the people. And then ongoing innovation is essential for maintaining quality and safety. So technology will never replace great surgeons, but technology in the hands of great surgeons will change the world for you. So I hope all of you will come today, gain more practice, experience, and most importantly, be confident in what you're practicing. Thank you so much.
Thank you very much, Dr. Atul, for showing us how to harness the power of digital resources in surgical education. Your insights will surely help us make the most of these tools. May I now request Dr. Nikita to kindly present a token of appreciation to Dr. Atul Kamath. A strong foundation in basic surgical skills is crucial to the making of every competent surgeon, and this session will guide us in strengthening those fundamentals. To shed light on this, I invite our next speaker, Dr. Vijay Pai, to please join us at the dais.
Okay, good morning all. I'll be speaking on basic surgical skills. I think much has been covered by the earlier speakers wonderfully well. So I will try and avoid those topics and touch on those aspects which I feel also needs to be understood and is also important. So if you look at the learning cycle, this is what happens. The first phase, look at a postgraduate who just joins a course. Right? The first phase is that of unconscious incompetence. That means he really doesn't know what he's doing and he doesn't know how to do it as well. The next phase is when he acquires some amount of knowledge. So that's the phase of conscious competence. Now he knows what is right, how it should be done, but somehow he lacks the skill that is required to do it. Now the third stage is even better. That's the conscious competence. That means your mind or your brain is telling you this is how you need to do it. It keeps reminding you, and that is how you are able to complete your task. And finally, that is the pinnacle that you are going to achieve, unconscious competence. That is a rhythm, a flow that you see. Things just happen. You don't have to think about it. It's just like a reflex. And that is the final stage in your surgical or any career for that matter. We all know this great man, right? You have a century of centuries in his name. But what we really do not know is how many hours he has spent in the net actually practicing. I would say that it is really criminal for a person, for a resident or anybody to go and operate directly on a patient in the present day scenario. You have fantastic wet lab facilities available all around you. Earlier speakers have spoken about developing your hand-eye coordination. Let me tell you one thing, suturing is one thing which is the most important. Do not neglect suturing. Invest in microsurgical instruments, buy a needle holder, buy a forceps and suture tying forceps and one tooth forceps. Practice suturing. Remember the rule of 10. 10-0 sutures in 10 minutes in your wet lab. That is what you need to do. Now just covering, I don't know how to start these videos though. I think much of the rest of it is already covered by the earlier speakers. So I'm just going to emphasize on your hand position during a cataract surgery. Both you can start, the other one also. So this is a routine cataract surgery. This is actually an unedited video. So on your left side of the screen, you will see the hand position. Now you see that the hands are rested properly on the face of the patient, or the rest that you have where the patient's head is resting. Please do not hold the conjunctiva with the forceps. Do not tear the conjunctiva. Your movements should be smooth and fluid. The other video is not playing. I think somehow we are not coordinated enough. Maybe you can start from first. Start from first, both videos. Start the right one first and then the left. Yeah. Yeah, that's fine. That's somewhat coordinated. Yeah. So look at the way the instruments are held. All your movements are with your fingers, with your thumb and with your index finger. Do not press on the posterior lip. Do not lose equus. Your incision is what is going to define you. It should barely nick the limbal vessels. Do not make an avascular incision. Those are very hard to heal. Learn to hold the cannulas and the syringes. Always make it a habit to hold the hub of your cannula. Sometimes if the cannula is loosely placed, it can just jut out of your hand and it will cause irreparable damage. Trust me, I have had this experience. So always use two hands to hold the cannula. This is another important step. The nursing assistant will give you a viscoelastic. You need to always make it a habit to tighten it. So tighten the cannula at the tip of the syringe that you have. While doing capsular access, doesn't matter what you use, you can just drop some viscoelastic on the cornea. That saves you the trouble of constantly wetting the cornea. You're using a cystitome here, two-handed technique. Your right hand or the dominant hand is the primary hand here, and your other hand is just stabilizing it. Do not press on the posterior lip. Do not lose the viscoelastic that is there in the anterior chamber. Now you're using a microforceps here to achieve the rhexis. Doesn't matter what technique you use. Ultimately, you should be learning all the techniques and you should be the judge, which is the one that suits you the best. Pivot in the incisions. That is the most important thing when you're handling the microsurgical instruments. Do not press on the posterior lip. Pivot in the incisions. You don't have to enter and re-enter the anterior chamber again and again. Again, while you are doing hydrodissection, make sure you have held the hub of the cannula there. Look for the wave of fluid. Decompress. Remember, there's only so much of space between the nucleus and the posterior capsule. Keep injecting, it will blow out. Have one more wave from the other side. And then try and rotate. Remember, if it doesn't spin, you're not going to win. So spin the nucleus. Hold the phaco probe or any instrument that you have like a pen. So hold it gently like a pen. Look at the second instrument, the fingers that you are using for holding the second instruments. All your movement should be within your thumb and the fingers, index finger primarily. So it doesn't matter what technique you use, the movement of the hand and fingers are of the prime importance. Look to your left side, the movement of the phaco handpiece outside. You see it's moving more than 30 degrees or so, but the movement inside the eye is hardly a millimeter or so. The entire surgical process should take place like a fine orchestra. Each particular step defines how your next step is going to be. Your fingers are nicely supported on the face of the patient, and everything is going on very smoothly as you have planned it. This particular patient in question has Fuchs dystrophy, so need to be extra careful here. So try not to work near the endothelium. While you are withdrawing, withdraw your second instrument first, not the phaco probe. Train your left hand, the non-dominant hand. See, here you are injecting viscoelastic using only with one hand. With your left hand you are injecting viscoelastic. See the way it is supported. Always look for a risk-free surgery. So do not do anything that you feel will give rise to some complication. If you see shallowing of anterior chamber, inject viscoelastic, form the anterior chamber, and then clear off all the cortex or whatever else that you are doing. Aim to achieve this flow. So once you have this surgical flow, so-called surgical flow or the symphony in question that you have, things will follow. And that is the confidence that you should be developing as a surgeon. No matter what is the complication that you create, you should be confident enough to handle it. Always remember, mistakes are bound to happen, but you need to convert those mistakes into lesson. How do you do that? By learning from it. Mistake is never a mistake, but it becomes a lesson when you learn from it. Here you see that I am not able to approach that small chunk of cortex. So inject a bit of viscoelastic there, form the chamber. More importantly, know your limitations. So these are some things which I can do, these are some things which I cannot do. Remember that you are not competing with anybody else. You are competing only with yourself. You need to be your own toughest critic. You need to go back, look at your own surgical videos, spend time with it, see what you have done wrong, and try and rectify it next time around. Have your mentors or your seniors look at your videos and let them advise you regarding what needs to be done. I think many times in an institution where you have so many people around you, you have so many nursing assistants, the staff, they do most of the work. But remember, once you are out of the institution, the only person who is answerable to you is you. Otherwise, you don't have anybody else around you. You are responsible for your patient, you are responsible for your machines, your trolley. You need to know in and out of your machines, your trolley, how to set up the equipments. say how to load your lens. Many times in many surgical centers, it's the nursing assistant who loads the lenses. So learn how to load your lenses. Now you have so many different types of lenses, so many different ways it can be loaded. So learn all of it. Remember to learn all techniques. When you are doing a phaco, divide and conquer is important, yes. Stop and chop is important. Direct chop is important. Learn all the techniques. Each of them will have its place. See what suits you the best. There's no right or wrong here. Somebody is doing a good divide and conquer, somebody is doing a phaco chop. There's nothing wrong in doing a divide and conquer. So while you are injecting the lens here, use your second instrument to fix the eye. So do not push the eye downwards. See how it is fixed? It's fixed nicely. It's important to have the eye in primary position. Many times I have observed when residents, they are operating, the eye is in some weird position and you are not able to actually get a very good red glow or the depth perception that you need. So keep the eye in primary position. Remember that the lens, objective lens of the microscope should be parallel to the plane of the iris that you have. That way you will get the best of the red glow and best of the depth perception. So these are some of the common mistakes which I have encountered, which I myself probably have made, not knowing your patient. So most of the times the residents, they just come to the operating table, somebody has painted, other co-PG has blocked, and you are just sitting and operating. You have no idea about the comorbidities of the patient. You do not know the other eye status. You just want to operate. Not knowing how to set up your equipments. Nothing can be worse than that. Somebody, I think, has earlier have given a lot of insight on how to drape and position the patient. Remember, eyelashes need to be sequestrated. You have all kinds of organisms on the eyelashes, and they are the primary cause of endophthalmitis. Remember to place your incisions well. Your incision is what is going to define the rest of your surgery. If you have a very shallow incision, it is going to leak. If it leaks, you will have shallowing of the anterior chamber while you are phacoing, and you will have a rent. Keep the eye in a primary position, always, and learn from every single case. So this is something which I have encountered in one of the articles in NET. So the x-axis actually shows the years, whereas y-axis is the skill level, and the blue line that you see is that of a surgeon who drops out, and red is that of a competent surgeon, and green is that of an expert surgeon. So, video run. So we'll talk about it a little bit more, while in the background you're going to see a video of a traumatic cataract with a fibrosed anterior capsule which is being operated upon. You look at the graph here, all the three graphs start at the same level and stay almost the same during the entire 3 years of residency, right? What happens to the blue line? Somehow he is not able to overcome the frustration barrier and just drops out. Look at the red line, that is of a competent surgeon. He is going to do what is being taught to him in the residency, and he will continue to do that his entire life. Not that he is incompetent, but that is how he is. He is somehow caught in that zone of mediocrity. He is not able to penetrate that passion barrier. Now the expert surgeon breaks the passion barrier, enjoys doing more and more the tougher cases. In fact, he tells his colleagues, if you have any tough cases which you can't handle, please send it to me, I will try to manage it. And now he becomes the true master of surgery. So true mastery doesn't mean that you stop learning. You still learn from each and every case. Remember that when we were postgraduates, we didn't have anti-VEGFs, we didn't have OCTs, we had LASIK and refractive surgeries had just come in, ICLs were not there. We all had to learn it later on. So learning is a process that never stops. So today, what is the best possible procedure as of now today is not going to remain like that in the next 10 years' time. It's going to be something else. So you have to keep evolving with time. So many times I have heard the postgraduate students tell me that they are probably not there in the right residency training program. They do not get enough cases. I always tell them it really doesn't matter how many cases you do, whether it's 50, 100, 200, doesn't really matter. What matters is how much you learn from each and every case. So that is what is important for a resident. So do not look at how many cases you are doing. Look at what you've learned from every case. Remember, it is not the horse that wins the race. It is the horse that wins the race, not the track. A good cook will probably, in any kitchen that you give him, will come up with a delicious or a very, very good dish. So it depends on your inclination, your learning ability, and the motivation that you have. That defines you, and that defines you, and that should be defining you for your learning. So these are, I feel that many times there are certain scenarios where you are so eager to operate, but you really, there are certain scenarios. A better surgeon probably knows when not to operate. One of them being unrealistic expectations. When the patient, 80-year-old man, tells you, I want to have the vision of a 25-year-old person, not going to be possible, isn't it? When the risk is more than the benefit, especially when you are looking at resurgeries. When there is uncontrolled comorbidities, remember that you are not just handling the eye, the patient is looking up at you as a whole. You have to look to the patient as a whole. If he has comorbidities like uncontrolled diabetes, cardiac issues, COPDs, not being able to lie down, you need to postpone your surgery until such time that he gets better. And most important is your ego, not knowing when to refer. So if there is something that you are not able to handle, there is nothing wrong in calling your colleague and helping him, asking his help. Please do not get caught in the spider web of complications. Learn from them. Thank you for a very patient hearing.
Thank you, Dr. Vijay, for reminding us the importance of basics. Your talk has truly underlined how fundamentals remain the backbone of surgical excellence. May I now request Dr. AJAY to kindly present a token of appreciation to Dr. Vijay Pai. Small incision cataract surgery remains one of the most widely performed and impactful surgeries in ophthalmology, and a structured approach can make all the difference in achieving excellent outcomes. To shed light on this, I invite our next speaker, Dr. Badrinath Talwar, to kindly join us on the dais.
Good morning, everyone. Thank you, Dr. Rajani ma'am, Dr. Ajay sir, and the AJ team, Dr. Devika, Dr. AKANSHA, Dr. Sharan, and Dr. Nikita. And also, I'm glad Dr. Asha is here. So this is a talk on something, after all the high tech, and we are going to something very basic, just small incision cataract surgery, a step-by-step guide. So I'll just change it a little bit. I'll just explain to you what I'm doing. So basically, you need to have some kind of an approach to when you learn. What are all the things you need to know about any surgery? So I just thought to make it a little different, I'll put it this way. So every step has got some checkpoints. What do you need to know? You need to know first, what's the goal? What's the target you want to achieve? Then what tools you have at your disposal? What are the tips? What are the helpful points that you can use to achieve the goal? And what are the traps? What are the things that you can do that will get you into trouble, that will make the subsequent steps difficult? and what we call the tell. The tell is in gambling, in poker, they look at the opponent and they kind of guess what's happening. So you look for a tell. So you have some kind of a crystal ball, or is the eye telling you something? What is going to happen next? Not next minute, but next second. That 1 second of advanced warning can really help you sometimes to avoid a complication. So let us see how it applies to a very basic step, say superior rectus. Now that's a very basic step. What's the purpose of the step? The goal is to rotate the globe downwards, get good exposure, good fixation, and then during the nucleus extraction, you want a good counter traction. That is your purpose. That's the target. What tools do you have? You've got the superior rectus forceps, which is a kind of a stout forceps. It has got a bend which is about 10 millimeters from the tip, and the superior rectus tendon is 7.7 millimeters from the limbus. So when the forceps bend is at the limbus, the tip will reach just beyond the tendon. It will reach the tendon itself, and you'll be able to lift up the tendon for the passing the sutures. Then what is the tip you have to use? You should know where 12 o'clock is. Once the eye is blocked, 12 o'clock may rotate. So you know 12 o'clock by looking at the ciliary vessels. The ciliary vessels will guide you to where is the 12 o'clock position. And you slide the forceps from the limbus posteriorly and keep the jaws wide as you go back, because you want a lot of tendon in the forceps. When you reach the required point, when the bend is at the limbus, then you pivot. You make the tip press on the globe, then close, and that will lift up the tendon. And the tendon is visible as a glistening structure. So it's not that you just blindly hold, you can see the tendon. So you want to look at that. So that video is showing this. So you start at the limbus, you slide back. So I have a little bit overshot, but anyhow, I'm trying to press against the globe. Now we have the tendon there. It's a glistening structure, clearly visible, better visible under the microscope. Apologize after the great quality of the videos. This is the best quality which I have in my microscope. And then you want to pass the needle, making sure that it is parallel horizontal, and not, the tip should not go into the sclera. It should be horizontal and up immediately. Once you cross the limbus, up immediately, avoid the vessels there. And then you can hold the needle tip, and you have to supinate your hand, take out the needle. So what is the trap there? The trap is you can have a globe perforation. So always pass under direct vision. Don't just pass. Always see the tendon, see the needle passing, and pass under direct vision. Lift the tendon up to create a space. Pass needle horizontally. That is correct. And do not pass needle pointing downwards, because that is going to perforate the globe. And a round-bodied needle is always better. As a PG, you may not have a choice, but if you have a choice, choose a round-bodied needle. And to avoid hematomas, avoid the blood vessels. So this is the traps to avoid. So what's the tell? How do you know where you got it correctly? The tendon should be seen clearly. The globe will rotate down when you pull the suture, and you'll have a good exposure, good fixation. So you know you've done the right thing. And perforation should not ever happen, but if it happens, how you'll know is when the eye feels soft and when you lose the lead globe because of the vitreous hemorrhage. So this is a kind of an example, a simple step, which you can break it down and you can look at what you need to do. So now if I do the whole surgery this way, it is going to be pretty a long talk, I think. So what we'll do is, let us look at what is the most important. So you got the lens. The lens is inside two containers. The inner bottle is your capsule, and the opening you're going to make is the rhexis. The outer bottle is your wound, and the opening you're going to make is the outer bottle is your eyeball. The opening you're going to make is the wound. So you got two bottlenecks, and they're not just bottlenecks, they are the rate limiting steps. If something goes wrong here, everything else is going to have a cascading problem. So you need to get this absolutely right. So we'll just concentrate on these rate limiting steps. So there's a triplanar tunnel which you want to achieve, that's your target. And it has to be a safe tunnel. Small SICS doesn't mean small incision cataract surgery, it means safe incision cataract surgery. It has to be a safe tunnel, should be stable as far as possible. If you have the slightest doubt, please suture. So there is nothing wrong in suturing. You don't become a smaller surgeon by suturing. You should suture if you have any doubt. You can try for a reasonable astigmatism, which is possible with SICS. And a smaller incision is less safe, though the SIA will be less. So there is one more concept called as the Cox incisional funnel, which means that the SIA depends on two factors: how close the incision is to the globe and how long the incision is. So it is said that it is directly proportionate to the cube of the length of the incision and inversely proportionate to the distance. Meaning if you go back, you can make the incision much longer. If you go forward, you need to make the incision smaller. And so the upper line shows three equivalent incisions. They're all astigmatically equal, wherein there's a straight incision, a frown incision, and a two straight incisions. They all fall within the funnel, so they are equal. The lower incision is a straight on the front, which is beyond the funnel, so this will cause more astigmatism. Then you have to think about why the front incision is such a good incision. So it is something like if you have a hanging chain, that's a very stable structure, which is the shape taken by a chain. It's called as a catenary curve. So like a suspension bridge. So basically when you create a front incision, you're creating a very stable kind of geometry, which makes the wound very stable. So that's why you aim for a front. But as a beginner, if you do a front, you're going to have a lot of problems because you'll start posteriorly and you will not actually reach close to the limbus. You'll find the whole wound is posterior. Then you have a very long distance to manipulate and subsequent steps become difficult. So better option is to use what is called as a Blumenthal or the batwing incision. So the corneal wound is, you initially make the straight incision close to the limbus, as close as you want, and then the two oblique cuts. So then you're able to control the distance of the incision. And to note that the inner wound has to be wider than the external wound. Why it has to be wider? Because the cornea is a non-stretchable tissue, whereas the sclera is a stretchable tissue. If the nucleus is brunescent, you make side pockets. Otherwise, you don't need to make side pockets because there's extra bulk in a brunescent nucleus. I think I've done something. Okay, fine. So then we come to the instrument. So now we talked, what are the tools you have? The tools you have are the crescent and the keratome and the 15 blade, if you use that. So you need 3 tools for the three planes of your incision. And the concept of bevel has to be understood. So the crescent is a bevel up incision. Imagine a dolphin. A dolphin's body is designed to dive. So because it's got a smooth upper surface, imagine the lower surface as a cutting edge, it's going to dive down. So your bevel up crescent is going to stay down as you tunnel. So the main risk of a crescent dissection is you'll have a buttonhole. The bevel up avoids your buttonhole. When you come to the keratome, there are 2 options. You have got bevel up and bevel down. If you have a bevel down keratome, it's something like a sailboat. It will sail forward. It will lift up. So if ideally in SACS you'll have to use a bevel down keratome, but it may not be available. So if it's not available, what you need to do is you need to dissect more into the cornea and then enter with the bevel up keratome so that you have an adequate corneal valve. So once you made the groove with the blade, then you make the tunnel. So I'll just show you something that I'm doing here. This is a batwing incision or a Blumenthal. We are converting the vertical groove into a horizontal groove by undermining. Now just watch here. What I'm doing is I'm trying to adapt the blade to the surface of the globe a few times so that my muscle understands how the curvature of the globe is. When you look at the globe through the microscope, you cannot understand how curved the globe is. That's a common mistake done. The PGs will dissect horizontally. The globe is not a horizontal structure. So once you do it a few times on the globe, you're kind of self-simulating and teaching your muscle how to dissect. Then when you go back, just let your muscle do the same movement again, and you will be in the right plane. With the crescent, you need to dissect more posteriorly. Most of the cutting is the backward cutting rather than the forward cutting. So I'll move on to the next slide. So I'm showing the same thing from the side so that to explain what I just said. So once we have undermined the edge to get a uniform edge, now put your crescent on the surface, not in the tunnel, on the surface of the globe, and see which movement of your fingers is going to adapt the crescent perfectly to the surface of the globe whenever you move the crescent all around. And just now your muscle is trained, just like Tendulkar practicing his shot. Now his muscle is basically, he doesn't need to do it, but he still does it because he wants to get his muscles tuned up. Now when you go in, you feel your muscle. More than what you see in the wound, you feel your muscle and it imitates the same movement and you are in the correct plane when you do the whole dissection. Just see how curved the globe is, how much it has to tilt to dissect the plane correctly. This is very difficult to teach with any number of words to a PG, but if they can do this exercise, they will be teaching themselves when they'll be learning this. I'm sorry, 1 second. Okay, so next thing is that about the entry with the keratome. So if it's a bevel down keratome, definitely need to dimple down. Not so essential if it's a bevel up. So initially you're dimpling down to get the entry into the anterior chamber. Once inside, let your hand relax and go back to the same position like it was in the crescent and dissect it in more or less the same hand movements as you used for the crescent. The tip should always remain in the anterior chamber, because if it comes back into the wound and goes back again into the anterior chamber, you're likely to strip the descemet membrane. So the same thing is being shown from the side. So you go sideways so that you don't prematurely penetrate the floor of the incision. Now you align your blade straight, you dimple down, enter the anterior chamber. Once you're in the anterior chamber, you see the cut margin of the descemet membrane, and then relax your hand, go back to the position it was in earlier, and then cut only when you're advancing the blade so that you get a clean cut. It's not a zigzag cut. So what are the things that can go wrong? The traps you can get into are the buttonhole and the premature entry. The buttonhole is when the blade rides up. The premature entry is when the blade goes down. So what will tell you that you're going to get a buttonhole? You'll get a buttonhole when your sclera is very thin. So the blade is more visible than normal. Normally when you look at the blade in the tunnel, the outline will be not visible, but the blade will be visible. If you can see the outline clearly, you're too superficial, you're going to buttonhole. The tissue will drag as you dissect. So as you dissect, you'll find the tissue is moving over the blade, and you'll see a small blot hemorrhage just before you are through the episclera. You'll see a small bleed there. If you stop there, you can actually maybe tunnel deeper and save the situation. So you look for that small episcleral bleed, which tells you that you're going to buttonhole the eye. The premature entry usually happens when your sclera is thicker above the blade. So means you dissected too deep, and you cannot see the blade clearly. So you're too deep. And typically what will happen is that when you're dissecting, you'll think the sister has given you a very good blade, or suddenly you're operating very well, because the dissection will be very easy as you go deeper into the tunnel. So when you see that the dissection is unusually easy than what you're used to, the resistance is less, you're going to have a premature entry. And when you have a premature entry, usually you'll also have a bleed in the anterior chamber, and so you know that you had a premature entry. So when you're, now I'll just skip because now we're talking about the wound. The wound has got two things. One, you made the wound. The purpose of the wound is to take out the nucleus. So instead of, we'll just jump to the nucleus extraction because we're talking about wound still. So when you talk about nucleus extraction, what do you want to do? Safely you want to take out the nucleus through an adequately large wound. And you want to protect the cornea with viscoelastic. You use your irrigating vectors properly and use the counter traction with the brittle force, the brittle suture. The tip is that you need to always depress the floor of the wound. Typically what you would be tempted to do is you would want to hold the nucleus in the vectors and you would want to pull out or pull up. That will cause the viscoelastic to get displaced and you will lose endothelial cells. Therefore, you have to press counterintuitively, you have to press the vectors down as you extract the nucleus. The trap is that if you start injecting saline early, iris will come out of the wound. It will be underneath your vectors, you will not see it. And as you extract, you're going to cause a large superior iridodialysis. Therefore, always depress the wound, let the nucleus settle on the vectors, only then inject saline and then extract. So the left side is showing you, and the right side is the same thing from outside. So the vectors is going inside. The nucleus in the anterior chamber already here. So we are inside. We're not injecting saline now. We are depressing the wound. Now the nucleus is on the vectors, and now we inject saline and continue to depress the wound as you extract. So in this particular patient, it's a thick nucleus and is stuck in the tunnel. And I'm going to use a Sinski and bring it out. But if the bulk of the nucleus does not come out, then be careful. You need to enlarge the wound. Here, most of the nucleus is out, so I can just put viscoelastic and I can rotate the nucleus out. But if most of the nucleus does not come out, if the equator of the nucleus is still inside, the wound is too small. So that is out now. Fine. So suppose your nucleus extraction is a problem. Now, how will you know if obviously if nucleus extraction is a problem, then you need to decide whether you'll try again or you will have to convert. Okay. So if you're finding difficulty, first check the internal wound. The commonest thing is that the internal wound is not large enough. That is the most common mistake. If that is large enough, then you have to dissect the side pockets of the crescent and enlarge the external wound also. And you make one more attempt. If 2 attempts don't work, it is better to think of converting. And the way to convert is to make it into some kind of a extra capsular trap. Means you make both the cuts vertically from the flap, reach the limbus, use corneal scissors to cut. Then you can suture the sides like an extra cap wound. You can suture the flap like a trap wound. It becomes simple. If you cut obliquely, then it becomes difficult because you'll have to do a lot of sutures to just get the same effect. So you need to think which would be the most easier way to suture. So when you do the rexus, you want a large enough rexus and to take out the nucleus. And it doesn't matter which way you do. You can do a can opener or you can do a rexus. And generally speaking, you can use the rexus needle, forceps or the microforceps. And for beginners, it's better to do the can opener because the commonest mistakes beginners make is make a rexus small. Beginners don't know how to make a large rexus and keep it controlled. So they can make a can opener capsulotomy, but you cannot hydrodissect forcefully. You can do a gentle hydrodissection. It has to be mechanical prolapse. Always keep the anterior capsule flat. And if it's a short eye or intumescent cataract, you need to use mannitol to help you keep the capsule flat. And use lots of viscoelastic when you do your rexus. So when you do a rexus, you can divide the task into 4 steps. First is to start with a radial cut from the center. So once you made a radial cut from the center, you pull on the edge of that cut and convert that into a curvilinear flap. Then you fold the flap over. So once you folded the flap over, then you start moving the flap. So you'll see surgeons doing a beautiful fast rexus. Don't try to imitate that. Break it up into the simplest possible steps. Make a cut, pull the edge, make a curved flap, fold the flap, and then move the flap. And in SICS, the rexus has to be large, preferably larger than the optic size. So what are the problems you can have? One is you can have a small rexus. The other is an extension. An extension is, imagine you're skiing down a slope and you want to ski around a mountain, but you're skiing down the slope. So chances are you're going to not be able to maintain a circular pattern. But if you're on a flat surface, you can comfortably ski in a circle. So basically, when the capsule is bulging forward, you're not going to be able to control the rexus. It is going to go peripherally. And as you operate, visco is escaping. So the capsule is bulging forward. The vitreous is pushing from behind. When the vitreous pushes from behind, the zonules are becoming taut. It is pulling the rexus peripherally. So you need to keep the capsule flat. Flat capsule means relaxed zonules. Relaxed zonules means a controlled rexus. So here we look at what happens. This is an intumescent cataract. So I've gone through the side port. This is a SICS case only. I'm making a kind of a curved flap so that the fluid escapes, not suddenly. And it's a controlled escape of fluid. Then you can go in with the empty syringe. Empty syringe means no air in the syringe. Empty syringe, vacuum. So go inside with an empty syringe and you suck out some cortex from the bag. What happens now is you can see the capsule is becoming concave. The convex capsule is now becoming concave capsule. Once it becomes concave or flat, you're in control. You can even go through the main wound now because now it's decompressed and aspirate some more cortex and make the capsule flat or concave. Once you do that, then you can make the rexus with the forceps because now there's a soft cataract, there's no resistance from the nucleus, so you will have to use forceps because the needle will have nothing to press against. I think we'll just, can we just jump a little bit forward? Just jump a little bit forward, please. Okay, fine. It's okay. I think it may take a little bit time. So the rexus is being done. Now what is happening here is, now it has escaped over there. So I'm going to change the uterata forceps. So first visco, flatten the capsule. Sorry, there's a bit of editing which should have happened over here. So I'm aspirating some more cortex, making the capsule more flat. Can you move the video a little bit further? Is it possible? Let's go to the next one. Okay, it's all right. Anyway, that was a double rexis. It's fine. We can skip and go to the next slide. Okay, so how do you know that the rexis is going to extend? See, when you make do a rexis, if you folded the flap carefully, you will see that there's a right angle where the capsule is folded and the cut margin is there. If you start seeing an acute angle, that means the angle is pointing outwards, the rexis is going to extend. Once you're trying to do the rexis, if the flap does not move, it has already reached the zonules. Once the flap does not move, you should not pull the flap because you already reached the zonules. Any more pull is going to make the tear wrap around the nucleus. So stop if the flap is getting stuck. Don't force the flap. When you're more experienced, you can do what is called as a Little's rexis rescue, which is something you can read about, but you need a little bit of experience before you can do that. So generally speaking, if the rexis extends, stop there and try to make a relaxing cut. So once you've done the rexis, you can do the nucleus prolapse. So one way is what we are used to, which is the hydrodissection, where you try to hydroprolapse, where you try to retract the capsule on one side and inject the fluid, allowing the fluid to come out of the bag. Once you've injected fluid and the nucleus is out, please don't take out the cannula immediately. Let the trapped fluid escape. Then put visco, and you have to look at, there are two corners, one in the nucleus, one pole which is out. So you have to support the corner which is nearest to you, lift it up, and move that corner towards the prolapsed pole side, where the pole is prolapsed. So in this case, I have to rotate left. Rotating right will not work. It has to go left ways. If the nucleus had come out the other way, then I would go the other way. So you go from the corner, lift up the corner, and move it towards the prolapsed side. So lift up that corner and push it towards the side that's already prolapsed. So you do it more times if it doesn't happen, one or two goes, and then you got the nucleus out. The left side, what we are doing is this bimanual method where you're retracting the capsule with the second instrument, pushing the nucleus centrally so that the nucleus margin is seen. Let that nucleus margin settle on your second instrument so it supports, and then rotate the nucleus over the second instrument. This is very helpful when you got a hypermature cataract where there's not much support. So IOL implantation is the next thing which I thought I'll just tell you about. So I wanted to talk about two things. One is the wound, the other is the capsule management. Making the wound, taking out the nucleus from the wound, making a rexis, and prolapsing the nucleus. There are two critical things where most of the time we get stuck. One thing which commonly happens is that we're not able to put the lens in the bag. After a beautiful surgery has been done, then the lens is partly in sulcus, decentered. So how do you do that? So basically there are three initial steps. You slide the leading haptic on the PC so that it gets under the anterior capsule, and put the trailing haptic into the anterior chamber so it stays in place. Put visco, deepen the chamber, and then you do three more steps. What are the three more steps? So now So the lens is going into the anterior chamber. Haptic is touching the posterior capsule, and then you slide in touching the posterior capsule so that the anterior capsule is now over that haptic. The second haptic is going to be put into the anterior chamber angle now. Leave it there. Put visco, deepen the chamber. Now look at where the dialing holes are. The dialing hole now is at the left side position, which would be in your case the 9 o'clock position. You need to bring it a little bit lower to around the 7 o'clock position. So why you want to do that is now you can grasp the dialing hole and pull it towards the other dialing hole. This will compress the haptic that is in the bag. The haptic in the bag needs to be compressed so that the diameter of the lens becomes small enough to push it into the bag. So you need to pull it, then press it towards the optic now, towards the posterior pole of the lens, and go. So there are three things you need to do. Pull, push, and dial. If you just dial, it's not going to go into the bag. Okay. So I think that is what I want to say in this particular topic. So you can look at every step, every single step. There are points to be thought about in which we can learn. And I think to mimic what ma'am said, what Sheetal ma'am said. So like basically athletes train, and we are basically creative athletes. Surgeons are basically creative athletes. We are not geniuses. And so you need to train if you want to get better. Thank you.
Thank you, Dr. Badrinath Talwar, for the clear and systematic guide on SICS. Your detailed explanation will certainly help young surgeons refine their skills. May I now request Dr. Rajani Kadri to kindly present a token of appreciation to Dr. Badrinath Talwar. Phacoemulsification has revolutionized cataract surgery, and proper training is the key to performing it with confidence and precision. To talk about this, I am delighted to invite Dr. Shaman Shetty to the stage. May we please have you on the stage, sir. Next, you can change the slides.
I thank the whole AJAY team, KUDVA sir, Rajani ma'am, thank you for having me. Thank you for this opportunity, and thank you everyone for here. This basically, I think I'll just try to tell you some things which I think, you read theoretically, but some I'll try to give a practical insight which can help you fine tune your skills. These are things which I think I learned at over a period of time, which I could fine tune it or learn by while teaching to others. So first is the biggest tip which we all have, like the failure. If we have a drop, if something happens, the failure, like when we know SIC is good, and again some kind of setback happens and we don't want to touch anything like this again. This 90% of us have. I can, openly tell you, like my first case as a phaco, I had a drop. I had done almost around 500 SICS at a good stretch. Everything is going fine. My first case is a drop. My confidence is shattered. Everything has gone wrong. I know, like, my patient is going to go next to the retina OT and it has to be managed right now. All said and done. So I'll show later where I actually went wrong. But when it goes wrong, your morale is shattered. So, but now the next best thing, two things which came to my mind. Now I'm anyways good in SICS, let me stick to this. Why this nonsense like this? This is not my cup of tea. My trainer and mentor said something to me which, kind of stuck to me, and it's still there. I tell this to other people, whoever it can help in any small way it is. You come to learn. This is a learning mistake. It's not a crime. A learning mistake is, there is a mistake which has happened unintentionally. It's not without your knowledge. Crime is where you know a certain thing and you're doing it intentionally. So a learning mistake is always forgivable because you don't know where it has gone wrong. What kind of, your step you have done which has gone wrong, but you go to assess where it has gone wrong, you try to rectify it. So that is how we have to, proceed. That gave me a push, like, okay, let me try to better it, let me try to learn where it went wrong, let me correct it, so that, I can improvise. So that will give you a confidence to go ahead. If we get stuck with one, liability, that should not make us just sit back. I'm just telling this because it should give confidence to others, like, don't stop. If you had a setback, it's fine. Just realize where it has gone wrong and try to, better it. This is something which again we have to keep in mind, to keep our ego out. We need to, certainly when we go to learn from others, we need to keep our age, whatever degrees, whichever things we have, to keep it aside. They might tell you the same 10 things or 9 things which you already know theoretically. It's there in the books, it's there in the videos, everything. But there might be that 1 to 2 catch points which that person might tell, can actually help you out. It might be a very easy manual which can simplify things. So please be open to learn. It's not like only you know the best. If that is the attitude which is going to go, then it's not the right thing. Be open to learn things from others. Maybe it's your colleague, your senior, your junior, whoever it is. But that openness will, simplify things for you. And that's how it has to be. Knowing SICS will give you a confidence in phaco, because why? Something goes wrong, there's always something to switch back to. Because suddenly what happens in phaco when you're doing, it takes a little bit bigger learning curve than your SICS. Each case is different, each thing what you do is different, each maneuvering, each technique, that to improvise and to get fine will take little time. So for that, knowing your SICS, if something goes wrong, something to fall back on, always helps you. So the surgical steps is usually pretty simple. A surgeon starts the surgery, he adjusts your phaco settings, he'll press his foot pedal, aspiration happens, the whole surgery is complete. This is basically how your phaco starts. But as a beginner, you need to know how you're going to go about it, what cases that you need to choose, what not to. Going on first with trying to go, like on table you have a subluxated, a mature or a dark black cataract, that is only going to decrease your confidence rather than anything. Pre-op things, just make sure you grade your cataract correctly. It is soft, hard, mature. See your pupil dilatation correctly, because the time you go inside and you have a small pupil, as a beginner, it's not good. IOL power, what it is, and especially your ECD, more than 3 millimeters, usually again it's going to be a problem. If possible to see your endothelial count, see that. A golden rule, whenever you're going to sit, always sit and see your settings. Don't go by settings of someone else. You have to see your settings according to your grade of cataract and what settings you are comfortable with. An expert setting, if you are going to go and sit with that setting, that is not going to help you. So always see your settings, see your bottle height, see how much water is there in your bottle. Everything is very important when you sit. Next is your sitting position. First, it's always better that you be comfortable, make your patient comfortable, then the rest follows. If you are not sitting correctly, if the patient is not sitting correctly, the head posture, everything has gone wrong, then that's not going to be a correct thing to start off with. A site of incision, see, it's again up to you. Like how I think Vijay sir showed his case, like, it's from superior, it's better to keep your hands, everything. It's one kind of a thing. But again, you can see there are advantages of it. Like how sir pointed out, you can rest out your hands. Incision is in the superior, your upper lid can cover it. There is a slight disadvantage in case of your deep set eyes, or we have a smaller palpebral fissure. So those kind of this is a slight setback. But if you're going temporal, that's also a good method. I use temporal because I'm more comfortable with it. I have a wider range, I have a bigger place, I can keep my hand. There is my hands are free to move for my chopping things also. And even if it is deep set eyes or whatever, it's not a problem. But yeah, like my incisions are not correct or anything, the pooling can happen. Sometimes your eyes can go a little nasally. So those are the again disadvantage what can happen. But it's left to you. You can choose whatever you want, but choose wisely, like how you want it and how you can correct it. There are usually 3 types of incisions which people follow. One, scleral. Yes, like as an initial beginner, you want to do a small scleral incision and then try to do your phaco, because if something goes wrong, you need something to fall back on. Second is limbal. Too much of limbal, if you're going to go in, again, you're going to end up with ballooning. That's again going to hamper your surgery. Too much of clear corneal, you're going to go, again, you're going to end up with wound burn. So exact a little bit between a slightly above limbal, it's going to be a little better, but you can go ahead with however, according to your case wise. Yeah, so a little bit I can just tell you about the incision to fine tuners. There is usually 3 types of steps which you can use. One is a one step which you can go deep and just enter it. It's very easy to put your probe to finish off your surgery. The only disadvantage is when it comes to your sealing things. The second is, yeah, I think you are able to see this. Second is usually what in a 2-step what you do is lightly you're going to make a groove, you're going to go 1 step and then you're going to go inside. So this what happens, it's slightly much more better than your 1 step, sealing is much better. next comes is like what you call as like a 3-step. In 3-step, what happens? Your astigmatism is still reduced. The chances of your not getting a full seal is very less. So it's still much more better. So if you can, incorporate it into your surgical, into your phaco cases, it will be helpful, because rather than straight taking an entry blade and directly going in. So these kind of small things, it helps us refine our surgical skills. Paracentesis is usually only like what sir showed. You take a side port or your MVR blade where you're going to do your rexus, basically make it such that your viscocannula can go inside and come out. The other chopper side should only be so much that only your chopper can go inside. Too much if you try to make it, then again you're going to have a leak there where your antechamber is not going to form. So this is, I'm just putting a pictorial representation. See, the first where like I'm showing, it's like a good, because you have like at least 2 to 3 clock hours away from your main site of incision. So this, what happens, it gives you a free flow for your hands to move. Your left hand has to keep moving, or whichever hand you are, that hand has to keep moving towards your phaco tip or movement of the nucleus. Again, in the same, when you're seeing in the second thing, it's very close. So very close, what happens when your probe and your chopper is going to be very close to each other, which it becomes very difficult for you to initiate a crack and to do multiple cracks and to give, to eat it up. Can we play this, please? Both, if it's possible. Yeah. So you're seeing that, see, like in the first thing, it's at least 2 to 3 clock hours there, it's there, but you're putting like, your type of incision is not correct. That's why you're seeing the ballooning happening there. In the second video, you're giving excess phaco, it's very close, and you're seeing a wound burn. We are not realizing this, but these small things, like slightly giving 2 to 3 clock hours away for your chopper, making your wound right, these kind of trouble, it saves you. Getting your rexus. Once you become little better, yes, you aim for a 5.5 to put your multifocals, all that premium lenses, it is better. But as a beginner, it's always better that you get a 6 to 6.5 millimeter rexus, so that like, you need to do your trenching, you need to split, you need to eat. So for this procedures to do, so you get a big rexus as a beginner, it is better. Once you fine tune it, you go to a smaller ones. Hydro is basically what, now it's exactly little different from what you do in SICS. SICS, you want your hydro to pop out the nucleus, but here you want it to be inside the rexus. Here, because you're going to take a probe, you want to do all your circus there, so you want the nucleus to be there. So, but when you do a hydro, the basic thing is, at least before you start your phaco, at least 3 clock hours it should move. If that is able to move, that means your entire nucleus is going to move. Maintaining your fluid balance in phaco, because we always used, get scared of the term surge or how the fluidics happen in phaco. It's usually gravity based. You see any normal old or regular phaco machines, it's all dependent on your bottle height. Usually around 90 centimeters above your head, that is how it is going to be placed. So this fluid is going to come into your eye, your pressure is generated, there is a fluid inflow, there is an outflow, and that is how a balance is achieved. Whenever this is going to create an imbalance there, that is where you are going to have a problem. Normal in your phaco, it is again, yes, it's like an unified control system which you have. There is a power which is going to be delivered, and there is a vacuum which you can control it. The emulsification happens in a very simple format. You are applying an ultrasound that is going to fragment the lens. With your aspiration, that is going to be emulsified. So I have just simplified it so that you can understand it. So how are you going to, crack it open? Usually there are 3 things, which is 3 usual simple techniques which you used. Either it's a stop and chop, divide and conquer, or your direct chop. So the normal trench, what happens is, what you see, like, within the rexus, when you come in with your phaco probe, from your one end of your starting of your rexus till the another, you have to be in the same group. Like how we tell, like you go to an ice cream parlor and they're going to scoop a layer of ice cream. The deeper you go, that is going to be a deep scoop. So you start When you're coming to the middle, you give a little bit more ultrasound. When you're coming towards the end, you lessen it. You stop, you come back, and you start from the same groove. You go 80% depth, or at least until you see like a red glow. It's not like you keep going, you keep digging until the whole thing gives away. You should know how you have realized like an 80% of your depth of your nucleus is correct. Then you can try to, split it. If that is not happening, rotate it again and again deepen it. That's all it is. But when you're going to split it, there are two usual methods like what people follow. One, you use the same probe and you want to use the chopper and try to do that. That is again happens when you have a very good foot control and that you're able to do it. But as a beginner, if you're not able to do it, put visco, take 2 choppers. The pressure only has to be on your fingertips. It's not on your wrist. So just keep it over the groove and try to, only it's just like a splitting motion. It's not like you try to rip it like open a shirt. That's the time when you try to do it like, AC starts collapsing. So the pressure is only on the fingertips. You try to split it. Once you have a split, then you're ready for your FICO 2. Maintain the groove. If you're going to try to make multiple grooves, then you're going to create a crater, which again you yourself are going to have difficulty to again split it again into multiple pieces. Because in FICO 2, again you need to do a horizontal chop to break the nucleus. So you will never get a grip. So initially it is very important that you do a correct trench, be in the same length, start, middle you try to trench more, when you're coming to the end stop. I'm showing this video why? Because initially when you start, there is so much of knowledge with us, like, you have read your dynamics, you have done everything, then you're concentrating same things. Your hand, your eyes and your foot has to be in the state, like present state of mind. Because something goes wrong, you don't know what is happening. This is exactly the step where I went wrong in my first case. I got everything right. When I started my trench, but when I had to stop and to come back, my foot didn't stop. It just extended my rhexis. That gave way for my nucleus to fall down. I didn't realize it that time. After it fell, once when the retina people were clearing, then I realized, okay, my foot pedal didn't stop. I had overpressed my foot pedal. It just took off. So that's the small things, like it makes a matter. You start, you stop. But just don't give giving FICO. You come back, you start from the same line, deepen it, stop, come back, start. Until you see like you got a good groove, that itself, like, it'll save you a little problem. Can we increase the sound or something? Yeah, so I'm telling this why, because in this part of listen to the sound means, here you need to listen when the vacuum is going to build, especially in your FICO 2. FICO 2, when you're going to aspirate all the cortex, you're going to go with your probe and you're going to touch the nucleus. It's always better that you touch the cortex, like, the core, you touch the core of the nucleus, because that is where you want the vacuum to build. Once that vacuum is built, you are going to, See, this is how like the aspiration is going to start. This sound is the sound when the vacuum is built. Your probe is already in contact with the nucleus and it is the vacuum of your desired choice is built. So that is the time you need to go and chop. Before that, if you're just going to press your foot, you're just going to be in an ultrasound 3 and you're just going to be around there, not going to build any vacuum, or not going to be able to do anything. It's why? Because only when this vacuum is built, you have your capacity, you have the movement to use your left hand to go and do a chop. So in this chop now, usually there are two things. Either there is an horizontal chop or you're directly going into a vertical chop. Horizontal chop, when you're coming into FICO 2, this is a small tip which I'm telling you. Please forget your trench action here. How we are going to go in FICO 1 with you're going to keep trenching. In FICO 2, try not to do that. Your idea is what? You need to take the piece, come to the center, be in the center, your probe has to be stable, your left hand has to move, eat it up. Here if you keep going around with your probe here and there, your vacuum is more. It's somewhere or the other, it's not going to be in your control where you're going to have problems. So the tip is like, forget your trench movement. Try as much as possible to keep your probe stable. So the next is like, how you are going to split it. In horizontal chop, you are going to use a blunt chopper. You are going to go little behind your rexus and try to make like an inverted L split. That is how it has to happen. As a beginner, if you are finding it difficult, you split again the nucleus into 4 quadrant, which again can help you to hold it like how you have done the 2 quadrant with your trench. The same you do with your 4. Once those are 4 small pieces, it's much more easier for you to go hold a piece, get it towards the center. The probe should not be facing up nor to down. It has to be middle, and then you start doing it. Vertical chop, it's usually again more of your NS2 to 3 little bit, or if you have some little smaller cases, but it will help if you have a little sharper chopper here, because you are going to be in the center and from there only you want to split it open. So this is again like once you are fine tuned with your horizontal chop, then this technique can help it much more better. Coming to the epinucleus part. So you finish your major part and now you're coming to the epinuclear part. This is the soft part. This is again where you get scared, like your foot pedal is not in your control. Something can go wrong anywhere. There is a thin sheet. If you put your foot somewhere, it's not going to be a control. So easier thing is if you feel it's not loosen, it's not coming close to you, means either again you go just to a hydro on the sides, so that will loosen it, or even you can put a visco and just try to use the dialer and loosen the epinuclear plate, so that loosens up. Once that is loosened, then you can go into your epi mode and then eat it up. When it's coming to the last piece, always be careful like about your foot movement. When the nucleus is going to touch your phaco probe, no matter what it is, you make sure your left hand is moving, you're eating the piece. Once that piece is eaten, you come back to 2. It is 2-3 foot pedal movement. If you cannot be in 3 or 2, if you are only in 2, you are not going to emulsify the nucleus. If you are in 3, you are just giving power, but you are not holding on to anything. So when again you are moving on to your cortex clearance, initially as a beginner, it is always better you start off with Simcoe. Why Simcoe? Because you need to have your hand and your foot control. So that will help you at least some 15-20 cases. You have your control over your Simcoe cannula to remove it. Then you go to the bimanual. Then you go to coaxial. Bimanual also, we tell this why, because it's a transition. It's a transition for you to gain confidence with your foot, gain confidence with your hand, and you see how the cortex is getting removed. If not, then again this is where the smaller things which can go wrong to you. Lastly, even for the IOL, even till the time you take the IOL, and as sir said, slowly you wait for the front and the last haptic to come. That is how. You just don't need to fast, just try to and push it. There is nothing wrong like in using like a wound assisted method, like how sir showed, like using a dialer which can stabilize your globe, and that helps you to put the lens. Because sometimes when you're going to use the injector and put it, invariably the eye will move. So that times you don't know where it is going. If it is not going, either it is going to come, or like you will, this is again half the times either you're pushing too fast, which is going to end up with a PCR, or you are going to end up with an IOL getting cut somewhere. So it's always better use whatever method suits you, fine tune it. So I'll just summarize the things. Means choose your case correctly when you're starting, optimize your microscope setting and your phaco settings. Create your settings again. As a beginner, I will always suggest you go in a linear mode. Linear mode is much better, like when it is in your control, rather than going to an expert mode. Expert is usually like what people are very fast, they used to fixed mode. Fixed mode as a beginner, it becomes very difficult, because the time you put your foot pedal, everything is in a F1 track. But being in a linear mode, it is going to take little time, but it is there in your control. Everything is in your control. You are able to do things on your own. So it is better that you keep your settings as linear in any kind of a machine when you are going. Gentle hydro, start with your divide and conquer, then you move on to the vertical chop, stabilize your hand movements, and as I said, inject IOL gently attack. So I concluded, like you need to know your dynamics. You need to know what is happening, why it is happening, what is pulse, what is burst, what are the modes, what's happening. Then you need to understand about your machine. So understanding a machine will help you to, fine tune your surgical things. You should know when you need to convert. If you are not able to manage, ask for help. Review your videos. You need to record it. You need to know where it went wrong, why it went wrong. Can you fine tune it? Is there some thing which you can do which can decrease your phaco time? All that things will help you. So yeah, it has a longer learning curve, but it's not an impossible learning curve. So yeah, just keep it in mind and keep doing surgeries. That's all I'll tell. Thank you for your time.
Thank you, Dr. Shaman Shetty, for guiding us through the nuances of phaco emulsification training. Your insights will inspire learners to approach this technique with clarity and skill. May I now request Dr. AKANSHA Shetty to kindly present a token of appreciation to Dr. Shaman Shetty. Simulation-based training provides a safe and effective environment for budding surgeons to gain hands-on experience, and this technology is shaping the future of surgical education. To shed light on this, I invite our next speaker, Mr. Karthik, to please join us at the dais.
Thank you, ma'am. Thank you so much. And thank you so much, Dr. Ajay and Dr. Rajani, madam, for this introduction. Thank you for inviting. Right. So what I'm going to present today is, before that, my name is Karthik and I'm a phaco development specialist from Alcon. And I'm honored to present how our educational initiatives, especially the Fidelis simulator and the coming programs that I'm going to explain in the coming slides, can support your postgraduate training efforts and elevate institutional outcomes. Before this, this is a disclaimer slide. Phaco development is a non-promotional and public service initiative by Alcon intended to increase access to cataract and eye care to deserving communities across the world. Currently, phaco development is active in India, China, and South Africa. The content and material in this presentation is no way intended to promote any Alcon products or its commercial use. So here is the video about Fidelis simulator. Sound, please.
Reality Surgical Simulator User Experience Guide. Once you have launched the Fidelis Surgical Simulator from the Alcon VR Command Center and have clicked on Sign In, you are now ready to explore Fidelis. Let's start with See Available Curriculum. From this menu, you will see that each step of the cataract procedure has been individualized to allow participants to focus on a specific skill set. Click on any step to enter the virtual OR. You are now in the Fidelis Virtual OR. A digital monitor is available in the OR, which features step-by-step videos for each step of the cataract procedure. To view the video on the monitor, guide the laser pointer from your right-hand controller to the play icon on the monitor. Select the play icon with your right index finger.
Paracentesis. What are the three foundational elements of a paracentesis?
Click the home icon to view the library of videos highlighting each step of the cataract procedure. Select a video or click back to exit the video library. To return to the virtual OR, use the laser pointer to click on the small arrows on the bottom right-hand corner of the monitor, pushing the monitor. To prepare for virtual cataract surgery with Fidelis, let's first explore the haptic engines. Remove your headset. Position yourself directly in front of the haptic engines. Notice the stylus attached to each haptic engine arm. Remove the stylus from the inkwell and hold it like a pencil. Place your index finger on the buttons. Note the front button and the back button. Return the stylus back to the inkwells. Next, Fidelis features an integrated Centurion foot switch. Place your foot on the foot switch, noting that 2 black pads on the left and on the right sides of the foot switch. While performing virtual cataract surgery, you can advance to the next step of the procedure by pressing the top of the black pad on the right with your foot. To return to the previous step, press the top of the black pad on the left with your foot. Now that you're acquainted with the haptic engines and the foot switch, you are ready to perform virtual surgery with Fidelis. Press the right arrow on the laptop keyboard to initiate surgery with the microscope view. Put the headset back on. Remove the left and right stylus from their inkwells. Notice your surgical instruments are hinging on a fulcrum. This is a calibration step. Once your hands are in a comfortable position on the handrest, press the front button on the stylus to release the instruments. Take a moment to familiarize yourself with the virtual surgical instruments. Notice when you hold the dark gray front button down on the stylus, it closes the forceps. Release the button to open the forceps. Press the light gray back button on the stylus to open the virtual instrument menu. Move your hand in a circular motion to dial the indicator around the menu. Press the front button on the stylus to select a different virtual instrument.
So at Alcon, we believe in immersive training. The Fidelis VR simulator, which we have seen now, offers a 3D surgical experience that allows PGs to experience and practice phaco techniques in a risk-free environment. It is already being used in wet labs and simulation sessions. Today, also we have this session planned, and this is related to technique practice. Now, when it comes to technique and technology training, learning, this program is their virtual residency program. It is part of that initiative and intense partnership with the key ophthalmic teaching institutes to offer an interactive learning platform to the ophthalmic residents and fellows on various techniques and technology pertaining to phaco and VR surgery. This slide outlines the structure of Alcon virtual residency program, which includes both the phaco development and vitreoretina development tracks. This model is built around 3 key components: the pre-read materials, didactic sessions, and self-drilled assignments. This ensures a progressive learning experience from foundational concepts to hands-on practice. This program is designed for junior and senior residents with little or no experience in phacoemulsification under the PD track, and VR fellows in the first 6 months of their fellowship under the VR track. Faculty from both Alcon and the host institutes guide the session, ensuring clinical relevance and mentorship throughout the structure. This structure allows institutes to offer a comprehensive, scalable, and customizable training experience for their postgraduates. Now, how to go forward into this? This slide outlines the collaborative steps we follow in surgically implementing the virtual residency program in partner institutes. It all begins with the intimation to the surgical sales team members, followed by an introductory presentation to the chief faculty members. This helps align the program objectives with the institute's academic goals. Next, we understand the specific needs of the residents and customize the curriculum accordingly. At this stage, we also complete the consent form formalities to ensure institutional alignment. Once the groundwork is set, we conduct an introductory call with residents to guide them through the pre-read materials, followed by mock session with faculty to ensure smooth delivery. The core of the program is the didactic sessions, where faculty share practical pearls and engage residents in interactive learning. Finally, we offer need-based surgical video discussion after the course, allowing residents to reflect on surgical techniques and receive expert feedbacks. This structured partnership ensures that the program is not only educational but also seamlessly integrated with your institutional training ecosystem. The programs and the content for these programs will be this one. There will be 2 levels in this residency program. Level 1 includes the basic concepts that will be discussed on that. And in the level 2, which has the advanced concepts like pharmacodynamics and PCR management and anterior vitrectomy management, and also the cell-filled clips, which will be discussed with the PGs, and they will be able to learn more concepts about it. Until now, we have discussed about, this is all at the institution levels. Now, Alcon has partnered with Arvind Eye Care System to create a learning platform for PGs. This program aims to provide ophthalmology postgraduates a unique on-site learning experience, enabling them to acquire essential skills, confidence in comprehensive ophthalmology, and understanding of best practice in cataract surgery. Additionally, this program aims to bridge the gap between the theory and practice. Additionally, the program and complement their training to meet global standards. These programs are 4.5-day session for first year PGs and 4.5-day session for second and third year PGs on a separate dates. The course structure covers something like this, with theoretical session on SASCs and phaco, quiz, group presentation, dry hands-on trainings on the diagnostics of different divisions, live surgery demonstration, wet lab hands-on training, and video assisted surgical training, and mock exams also for the final year PGs. Thank you.
Thank you, Mr. Karthik, for introducing training. It is exciting to see how technology can accelerate learning. We now request Devika to kindly a token of appreciation to Mr. Karthik. Okay, sir. We now come to the concluding part of this second scientific session. May I now request everyone to kindly stand for the national anthem. Jai Hind. With that, we bring the morning session to a close. On behalf of the organizing committee, I extend my gratitude to all our speakers, panelists, and delegates for your active involvement. We now proceed for lunch, which is arranged at the dining area. Kindly join us and enjoy the hospitality. Please note the program will resume at 1:30 with the wet lab session.